Hello, good morning.
Good morning, sir.
Yeah, can you hear me?
Sir.
Yeah. So 10:30 we are starting, right?
Sir, we are waiting for some more people to join.
Yeah. So I'm here.
Yes, sir. Yes, sir. Soon we will start with the inaugural session.
Okay.
Good morning,
Hello,
Dr.
good morning, Dr. Hussain. Good morning, sir.
Good morning. Nice to have you.
Yeah. Meeting after a long time.
I know, seriously. I was trying to,
Yeah. I remember you coming from
Dr. Ajay is around?
long back.
Sorry? Yeah.
Calicut.
That's what I was trying to recollect.
Yeah.
Recollect, exactly. How are you doing? All going good?
And I don't know, sir,
All
whether you
going good.
remember, you are a faculty when I was doing my BDS in Manipal.
I was a PG. I was a PG, right?
Yeah, you were just leaving. Yourself, Dr. Denny, and Kenneth and all. Kenneth.
Yes. Yeah, they were juniors. Kenneth were juniors.
I remember you are there in the end of your MDS.
Probably, yes.
I think
Nice to see you.
What, 10 minutes time?
Yeah, I know. I think, right on time. Yeah. Dr. Ajay Naik is around? I didn't see him.
Sir?
Good morning, sir.
Dr. Ajay, good morning. Hi, Dr. Ajay. How are you?
I'm good, sir. How are you, sir?
I hope the Bombay floods have receded now.
Yes. Every year it's a thing that
You're in
we are
Mumbai,
used
right?
to
You're in
know.
Bombay.
Yes, sir. I'm in
Yeah.
Mumbai, sir. Yes, sir.
I know. Good to have you guys.
Yes, sir. Good
Dr.
to see
Joyce,
you,
shall we
sir.
start? Good to see you too.
Yes, sir. Shall we start, sir?
Yes. Dr. Joyce, start. We are on time. Do you want to give another few minutes for people to join in? Or do you have
Yes, sir. Just 2 more minutes.
forum? Okay.
Good morning, Ajay. Good morning. Good morning, Somi.
Good morning.
How's it going?
Micah. Wait, not right then. Shall we start, sir?
Yes.
All right, sir. A very good morning, ladies and gentlemen. On this fine morning, on behalf of the Department of Oral and Maxillofacial Surgery, Yenepoya Dental College, Yenepoya deemed to be university, we welcome you to the virtual CD program on benign tumors of orofacial region. Myself, Dr. Vinay, and my colleague, Dr. Ashwin, will be hosting this event throughout this day. We are humbled to receive the overwhelming response from all over the country for this event, and this is our first attempt to conduct the CD program online. So we kept it very short and half-day program with 2 eminent speakers followed by a panel discussion. Without wasting any more time, we quickly move on to the inaugural session. So now I request Dr. Joyce Sequeira, HOD Department of Oral and Maxillofacial Surgery, Yenepoya Dental College, and also the organizing chairman of this event, to deliver the welcome. Over to you, ma'am.
A very good morning to one and all. A very good morning to one and all. On behalf of the Department of Oral and Maxillofacial Surgery, Yenepoya Dental College, I welcome you all for today's virtual CD program. The topic for the orofacial region. So they may be originating from many structures which are surrounding the bone. That may be from the epithelial tissue, fibrous tissue, adipose tissue, vascular tissue, neurogenic origin, etc. And it forms a major bulk for a oral and maxillofacial surgeon's work. And hence it is important to stay abreast with the recent concepts and advances in the management of these type of tumors and lesions. I extend a warm welcome to our chief guest, Dr. Akhtar Hussain, Dean Yenepoya Dental College, who has always been supportive and has encouraged us in this endeavor. So in the last our HOD meetings, he mentioned that there should be CD programs from the departments, and immediately we decided to have a CD program in the virtual mode immediately. I welcome our speakers, Dr. Ajay Nayak, Chief Radiologist at Insight CBCT Imaging Center, Mumbai. He was working with us as our colleague few years back. Now he has been shifted to Mumbai and been settled there and then doing excellent work. I welcome you, Dr. Ajay. I welcome Dr. Saumitran, Professor and Head of the Department of Oral and Maxillofacial Surgery, Government Dental College, Kozhikode, who has graciously accepted our invitation and spared their valuable time to share their knowledge and expertise with us. I welcome you, Dr. Saumitran. And I welcome all the heads of the departments, faculty members, and the postgraduate students to this CD program. I wish the program all the success, and I am sure the participants will benefit immensely from the scientific deliberations. And we are conducting a panel session also. I request all the delegates to stay online for this panel discussion as well. Thank you one and all. Have a nice day.
Thank you, ma'am, for your warm welcome speech. Now I request Chief Guest of the Day, Dr. Akhtar Hussain, Dean, Yenepoya Dental College, to address the online gathering. Over to you, sir.
Dear guest speakers, Dr. Ajay Nayak, Dr. Saumitran, Head of the Department, Dr. Joyce, Dr. Jagdish, Dr. Vinay Krishna, the coordinator, other faculty members, my dear postgraduates from Yenepoya and around the country. A very good morning to you all. One of the good things that this pandemic has brought is the new method of interacting with people across the continents. So that's why it's possible to have speakers like this, who can address us. And I think this is going to be the order of the future all through. Even if the pandemic is cleared, there's a great advantage of interacting with people from across the globe. And I'm very happy to address not only our students, but also across the country. It's an amazing situation, which will, I hope, continue and maybe with better than what we have today. We had webinars continuously, but somehow we lost that CD because of this kind of pandemic problem. But I'm really happy that the Department of Oral Surgery and Dr. Joyce has taken up this first CDE, since a couple of speakers, not just one webinar, also followed by panel discussion is a very interesting thing to happen. And the panel discussion, of course, is going to bring in a lot of new knowledge. And diagnostic dilemma in benign tumors of orofacial region, tumors. Now, this holds a constant dilemma among the maxillofacial surgeons, owing largely to its asymptomatic nature and also the slow growth. Since the patient also report for treatment very late or don't even report to the treatment. And we have to understand that the prevalence of tumors is increasing day by day. It's on the rise. I think from about 3% in 2005 to about nearing 6% in 2020. And this cannot be ignored. And even if you look at literature, even if you go online, they all talk about malignant tumors, very less about because I think this is much safer probably. But much more is talked about malignant lesions. But I feel, at least 4% of these lesions can get into malignancy. So it's very important that we understand diagnosis very early. So a lot of problems can be reduced to a lot of our patients. So it's we have Dr. Ajay and Dr. Saumitra, giving this talk, which I'm sure all their lives, what have they developed, they learned, they're trying to give to all of us. And I think which should not be missed, especially by postgraduates. And I really thank them again, both our guest speakers, Dr. Ajay and Dr. Saumitran, for their support. And of course, I appreciate the team of oral maxillofacial surgeons, headed by our dynamic head of the department, Dr. Joyce. And I wish the deliberations all the success. Stay safe, stay blessed. Thank you.
Thank you so much, sir, for addressing the gathering. Now we will move on to today's program. The first guest lecture is by Dr. Ajay Nayak, who will be introduced by Dr. Arvind Rao, Additional Professor, Department of Oral and Maxillofacial Surgery, Yenepoya Dental College.
Good morning, everyone. It is my privilege to introduce the first guest speaker of the day, Dr. Ajay Nayak, a well-known name in the field of oral medicine radiology. He is an alumni of Yenepoya Dental College. He's completed his BDS in 2002 from Bapuji Dental College, Davangere, under the aegis of Rajiv Gandhi University of Health Sciences. And he went on to complete his MDS in 2006 in Yenepoya Dental College, under the aegis of Rajiv Gandhi University of Health Sciences. He has exclusively been practicing in oral medicine and maxillofacial radiology for his entire career. He has worked in colleges in Mangalore, Manipal, Nashik, Karad in academic roles involving undergraduate as well as postgraduate instructions and faculty. He is currently practicing as a chief radiologist at Insight CBCT Imaging, India's first exclusive 3D maxillofacial imaging center, Mumbai. He has been working there since 2013 till date and managing 7 Insight CBCT centers. He has been a keynote speaker at various state, national, and international conferences as well as workshops. He regularly conducts workshops at CBCT imaging in India and abroad. He has presented various winning papers in specialty, interdisciplinary, and general dentistry conferences at the state and national levels. He has also published various papers in reputed national and international peer-reviewed index periodicals and written a chapter on orofacial pain in a textbook. He is on the reviewer panel of multiple peer-reviewed indexed international journals. His main focus of practice in Mumbai has always been 3D maxillofacial imaging and oral mucosal lesions. Ladies and gentlemen, I present to you Dr. Ajay Naik.
Thank you, Dr. Arvind. Very good morning, Dr. Akhtar Hussain sir, the Dean of Yenepoya Dental College, Dr. Joyce Sequeira, Dr. Jagdish Chandra, Dr. Vinay Krishna, Dr. Arvind, and all the other faculty members of oral and maxillofacial surgery. Very good morning to my teacher, Dr. L.K. Chhatra, who's also in the meeting today, and my other teachers who are also there. I would like to say that thank you for the opportunity, Dr. Joyce and Dr. Jagdish, for presenting what I have learned in the past 15 years. I will now start my presentation without any further ado. I hope I'm audible to everyone.
Yes, sir. Very clear.
Yeah.
No problem.
Yeah. Is my screen visible now?
No, not visible.
No, sir.
Just 1 minute. Now is it visible?
Not yet, sir. I think you have to present.
Yeah, I'm sharing. Now?
Yeah, yes, sir.
Yes, all right. So good morning. We'll start with my topic, diagnostic dilemma in the benign tumors of the orofacial region. Now, diagnostic dilemma is a very broad terminology, and benign tumors by themselves are a very broad terminology. And like Dr. Akhtar mentioned, that though there's not much talk about benign tumors, they also pose a very significant challenge in clinical practice. So let's see how we can simplify this, maybe not go through the entire gamut of benign tumors, but to a specific subset of benign tumors that we can cover in the limited time that we have. So orofacial lesions, there can be a multitude of orofacial lesions, right from the mucosal lesions to the bony lesions of the various parts of various tissues of the odontogenic complex, of the non-odontogenic tissues, the fibrous tissues, the connective tissue, a lot of these tissues. So today we will focus more on the neoplasms, and in the neoplasms, we'll be focusing more on the benign neoplasms only. But benign neoplasms are not to be neglected very significantly because a few of them can turn malignant. And if we disregard the malignancy potential, benign lesions by themselves can cause disfigurement and can cause morbidity, which can be a major loss of the patient's personality. And that's a very important factor that my teacher always taught, that don't treat the lesion, but treat the patient as a whole individual, because the patient is just not made of parts and tissues. It's the patient as an individual who's affected by lesions or the surroundings or the reaction of the people to the problems that the patient has. So we have to look at the patient as a whole individual and look at the problem that might be happening to the patient and affecting his or her lifestyle. So how do we go about solving dilemmas? We have to do the clinical assessment. Once the clinical assessment is done, we then perform the imaging modalities. There are a host of other investigative modalities that can be involved. But today, primarily, I'll be focusing on the imaging aspect that is more helpful, because we do not have to perform any invasive procedures on the patient. Everything is usually done from outside the patient's body, and yet we get a lot of information. It may not be 100% accurate information always to be very specific as to this is the lesion, but it gives us a very broad idea as to what might be happening and what further needs to be done. So I'll be predominantly basing this talk on case illustrations rather than focusing on the theoretical aspects, because determining case illustrations, it helps us easier to understand how exactly these dilemmas come about and how they can be sorted out. So what do we mean by clinical assessment? Clinical assessment just does not include clinical examination of the patient. It always starts from history. If anything, I remember from what my sir taught me, it was always have a very good ear. Listen to the patient. Listening to the patient is absolutely crucial. And why is it crucial? Because the patient has not read a single textbook that we have been reading over the years, but the patient is suffering himself or herself from that particular condition. So he or she knows what is happening to them at that point of time. They will give us a lot of information. And if that is sifted through carefully, a very detailed analysis can be attained. So what's the first thing that the patient will usually come to us with? Whenever there is a tumor, there will usually be an enlargement or a swelling in the jaw or the orofacial region. Now, these swellings can usually start very slowly. They are of very insidious onset. So the patient will very specifically say that this has been there for quite some time. It was not within the last few days or few weeks. So this insidious onset is very important to understand, because that is how the pathogenesis of a tumor goes on. A neoplasm usually starts slowly. If it is malignant, it will turn very rapidly, but the turnover time of a benign tumor is very less. So it is insidious in onset and very slow in growth. Now, slow can depend from lesion to lesion. Within the benign tumor subset, there are some tumors which grow pretty fast and some which grow very slowly. So usually it grows over a period of months or years. And very characteristically, the patient will say that it is not associated with pain. Now, this is not the whole absolute truth. Some of the tumors may be associated with pain, but the majority of them are usually painless. But they can get painful if they undergo some secondary infection. Once the secondary infection sets in, the signs of inflammation become evident. So a tumor may appear as something else. So that's a dilemma that has to be sifted out through careful history taking. The characteristic, the hallmark of benignity is that they will never metastasize. That means they will always remain local to whichever area they have arisen from. So if it is arising from the mandible, it will remain within the mandibular area. It may grow to a very large extent. I will show a couple of cases, but it will remain localized to the mandible. If it is somewhere in the maxillary complex, it will remain there. Whereas in malignancy, once it starts there, it will then spread to other areas. So this is one of the hallmarks of division between the benign tumors and the malignant tumors. Usually, many times is what I have found in my practice, many of these tumors get detected on routine radiographic examination. Now, the patient came for some other purpose and got a radiograph done. On the radiograph, something showed up, and then further investigation was done, and finally it was concluded that it was a benign tumor. So this is a major thing that happens because the patient is not aware, the clinician is not aware, and then a radiograph is taken, and then suddenly a lesion is detected. The next thing is the clinical examination per se. So when we perform the clinical examination, the very first thing that is usually seen visually on inspection is that there will be a very smooth enlargement if it's within the jaw. If it's in the soft tissue, the enlargement will be there, need not always be smooth, because there can be differential areas of growth within the same tumor. It's usually solitary. There are certain lesions which appear in multiples, but most of the time the benign tumors of the orofacial region happen in solitary manifestations. On palpation, usually these tumors are firm or hard to touch depending on where the tumor is. If it is partly or completely within the soft tissue, then when we palpate it, we will find that it is usually firm on touch. If it is within the bone and has expanded the bone, it leads to a hard palpation. Now, depending upon the various consistencies, the literature talks about various things. It can be firm or rubbery in nature. It can be firm like a tennis ball. It can be hard like a golf ball, or it can be stony hard. So it depends on the various manifestations of the various kinds of tumors that are there. The other characteristic of benign tumors is it is very well defined most of the time. If not completely within the clinical examination, later when we perform the investigations, especially the imaging, we will find it to be well defined. Now, why is it well defined? Because again, in the pathogenesis of benign tumors, the hallmark is it will usually up to 95% of the benign tumors are capsulated. Need not always be a soft tissue capsule, but whatever is the tissue it is made up of, it will be a very well-defined outer layer. So this well-defined thing helps us determine that it is a benign pathology and not something which is malignant or inflammatory. So something which is inflammatory or malignant will not usually be well-defined, and that will be more spreading in nature. Whereas a benign tumor, it will be very well-defined and localized. Also, we can find certain other things which are characteristic to the maxillary and the mandibular region because we have teeth and the other supporting tissues. So we end up seeing features such as tipping of teeth, migration of teeth, mobility of teeth. So once you feel mobility of teeth, you have to be very careful that you don't dislodge the teeth. At the same time, do not rupture any lesion that is there under. But that gives us an idea, yes, there is definitely a lesion and it is causing its effect upon the teeth. So this helps us understand that there is something happening there, and we'll see later how the teeth get affected in the particular cases. Next comes the investigative modalities. Now, from my perspective as a radiologist, I will be focusing on the radiographic interpretation of the tumors that we are going to discuss today. And investigating benign tumors is usually it starts in the dental clinics with two-dimensional imaging. So in two-dimensional imaging, a few terminologies that I'd like to make you familiar with. All of you must be familiar already, just brushing it up. Radiolucent and radio-opaque. Now, these are the terms that we use depending upon the shadows that are cast. So anything that appears black or more towards the black part of the gray spectrum, we label it as radiolucent. Something that appears white or is calcified or goes more towards the white spectrum on two-dimensional radiographs, we label it as radio-opaque or radio-opacity. Then we go on to three-dimensional imaging, which is very commonly available now. All of you must be familiar with them. So we have CT scans. And why I'm telling you these terminologies is whenever you do send these patients for three-dimensional imaging, the report that the radiologist, either the medical radiologist or the maxillofacial radiologist will provide you will have these terminologies. So CT scans will have the terminologies as hypodense or hyperdense, similar to hypodensity or hyperdensity of the structures that are seen. Now CT scans, even CBCT scans that are done are a type of CT scans. So that is the terminology that you will see on the reports. Then we have MR scans. And in this MR scans, what we will see is something called as hypointense or hyperintense areas. So MR scans are a little different from CT scans. CT scans are a more advanced modality of two-dimensional radiographs. So what we classically see as radiolucence starts appearing hypodense in CT scans, but that cannot be said the same thing for MR scans. Now in MR, what appears hypointense can appear hyperintense in some other sequences. I will show you one particular case to illustrate this difference. Then we can also perform ultrasonography in which sound waves are used. So the terminology that is used for the description of the lesions that are seen on ultrasonograms are hypoechoic spots or hyperechoic spots. But usually the imaging modality that is preferred are two-dimensional radiographs. To begin with is panoramic radiograph because that gives a very large area of the maxillofacial region and it's used as a screening radiograph. It shows us that yes, there is some lesion where to where it might be, and then it helps us decide what further three-dimensional imaging can be done. When we take any imaging, what is the first thing? We are going to evaluate in 4 basic parameters. The first one is the location. Now, why do we need to know the location? because certain tumors have a predilection for certain parts of the jaw. Like some tumors are common in the maxillary jaw, some tumors are common in the mandibular jaw. Now, though we say that they're common, does not mean that those which are common in the maxilla will not manifest in the mandible, or those which are common in the mandible will not manifest in the maxilla. It's the majority of the lesions go around that. But unfortunately, in the clinical scenario, the tumors nor the patient has not read any of our textbooks or not gone through any of the literature that is available. So the tumor will manifest exactly how it wants to, and then it becomes our job to find out what exactly it may be. So when we look at the location, the other clue is within the jaw, be it the maxillary jaw or the mandibular jaw, some parts of the jaw are more prone for occurrence of odontogenic benign tumors. Now, why odontogenic benign tumors? Because the odontogenic apparatus is present within those parts of the jaw, usually the alveolar processes of the maxilla and the mandible, because this is where the dental tissues undergo development, right from the embryonic stage till about the tooth is supposed to be formed. There are n number of steps, and anywhere if there is some discrepancy that happens, it starts manifesting as a pathology. One of the pathology can be neoplasms, and that can be benign tumors. So we need to see what is there and where it is. So if we see some tissue lesion which is there in the alveolar process, if it is above the mandibular canal in the mandible, more chances that it is going to be of odontogenic origin. Similarly, if we are suspecting some vascular or neurogenic problem, so where will it be present? Where the vascular and the neurologic tissue is present more. So if it's in the mandible, more likely that it will be manifesting within the mandibular canal or the whereabouts, which is where more vascular and the neurovascular bundle exists. If suppose it's a benign lesion of cartilaginous origin, now that will be present where cartilaginous structures are present. So within the maxillofacial complex, usually most of the cartilaginous structures get solidified or ossified by the time the patient attains puberty. Very rarely, some of these benign tumors of cartilaginous origins can be seen around the mandibular condylar region. The next parameter that we will evaluate on imaging modalities is the periphery and the shape of the lesion. Now, why is this parameter important? Now, the periphery gives us a very important factor, like I told you in clinical examination. The same factor applies in the imaging modalities as well, that benign tumors are usually well encapsulated. They will have a very definite border or a periphery where it will be very well defined. Now, the well-defined border may be corticated or may not be corticated. Now, what do you mean by cortication? Wherein it has a very fine or a very clear margin which is ossified. So that tells us that that lesion has been there for quite a long time, and the body or the bone has been able to deposit itself into more ossification so that a cortication forms. Because that is the way of the body trying to contain the neoplasm, saying that you are a problem and I don't want you to grow further. Of course, the tumor will exert more effect upon the surroundings, but usually the periphery will be well defined. And if there is a soft tissue capsule, we will see it as a radiolucence or a hypodense band around the lesion. So the periphery will be hypodense, even though the internal structure may be having some radiopacity, which brings me to the third point that we will evaluate, the internal structure. So we have to see how the lesion looks internally. So what is there inside the lesion? Now, everything can't be seen on radiographs or imaging, but most of the things what are seen give us a lot of idea. If it is completely radiolucent, usually it will be either filled with a fluid material or some soft tissue which is not casting a shadow. If it is completely radiopaque, then it is a lesion which has completely calcified, or either it has produced its own calcification or it has produced areas of the bone which are residual, right? So that can happen when it's a mixed radiolucent radiopaque lesion. So that is how it is seen when we see, and in the calcification also there are various patterns of calcification. Certain classic patterns appear where they can be clumped radiopacities or they can be scattered. Various types of radiopacities are seen. So the way we differentiate is, if it is fully radiolucent, the first thing usually we kind of suspect is it might be a cystic in nature. But benign tumors also can turn cystic, or cysts can at times turn neoplastic. So that's why we have to be very careful when we look at the internal structure. And finally, the fourth parameter that we are going to evaluate of the lesion is what has been the effect of that lesion upon its surroundings. So once we get to the effects, that gives us a clue as well. So like I mentioned in the clinical examination, we will be able to see very commonly the benign tumors, they will cause displacement or tipping of the teeth. So what happens is whenever there is tipping of the teeth, the long axis or the axial inclination of the teeth start changing. The cortices, they start thinning or they can cause expansion. Like you can see that this is how it will start growing. It will start expanding here. Initially, the lesion was just this small. Then when it started growing, it started affecting the tooth. It started affecting the inferior border of the mandible in this particular case. Here it's starting to tip the roots away. So when the roots get tipped away, the crowns start coming closer. But that might be sometimes a presenting feature clinically. So these are the various effects. The other thing, because of the pressure that this lesion is causing upon the tooth, it can cause resorption, most commonly resorption of the roots. So whenever there is resorption of the roots, the resorption can be very smooth resorption, or at times it is very sharp bevel-like, which we call as knife-edge resorption. I will show it to you in a couple of cases. So these knife-edge resorption again tell us that this is a aggressive lesion, yet it is benign. Because when there is a malignant lesion and it causes root resorption, usually it will cause the appearance of spikes in the roots. Because a malignant lesion is eating things away so fast. That's how the nature of a malignant lesion is. So it will cause irregular resorption of the roots and it will cause very spiky level of the roots. Whereas when a benign lesion affects the roots and causes root resorption, it will give a very smooth root resorption or a very sharp outline can be seen. So that is the differentiation that we can see in root resorption. A very important factor that helps us determine whether it's a benign lesion which is causing this effect or if it's a malignant lesion. So what are the dilemmas that can usually come? It may not be always pathologic. There are some anatomic structures which are there in the maxillofacial region, which on imaging can appear like a pathology. So the very classic thing that we can see is the maxillary sinus or even the nasal cavity, especially on intraoral radiographs. When an intraoral radiograph is taken, if it is not clearly taken in the right angulation, at times the maxillary sinus can appear like a pathology, or a pathology can appear like the maxillary sinus. So that is the differentiation that needs to be done. Rarely in the mandible, there can be enlarged marrow spaces. So these will have to be differentiated from an actual lesion. In pathology, there can be cysts, there can be tumors, there can be fibrous lesions. All of these can start as radiolucent lesions. There is a list of lesions apart from the ones that I have shown here, but these are the more common ones that we see in practice. And in these two, it's not possible to delineate every one of them today, given our paucity, and then we have the surgical aspect to be considered in the next talk. So I will focus my case illustrations primarily on the odontogenic lesions, that benign lesions that we see, and more common ones like the Amiloblastoma and the keratocystic odontogenic tumor. So these are the more common ones we see, and I'll show a lot of cases of these lesions. I believe in this adage which says that a picture is worth 1,000 words. So in the imaging, it is always easy to look at the case illustrations with a lot of images. My purpose of showing these images is that you will remember seeing these images and that there was some pathology. This is how it appeared. And once this is how it appeared, then you will investigate further that, okay, maybe there is something. So hopefully these images help you see what it may be. Some of them are the classic ones as described in literature. Some of them are deviating from the classic description that is given in literature. These are the cases that I have seen in the past few years. So I'm just presenting, and these are just few representative cases. These are not the absolute. Some of them are, like I said, very classic. Some of them are completely deviating from the classic. But here are few of the cases. Before we start the cases, I would like to have a very small discussion on the planes of assessment. Now, these are the planes that we have in the body. I hope everyone is familiar, these anatomic planes. When it goes through the midline like this, it goes through the sagittal suture. So we call this as a sagittal plane. So whenever we see something on the sagittal plane, we look at things in the anterior-posterior direction. So we will see things that are there anteriorly, as well as we will see which are things which are posterior to them. Especially in three-dimensional imaging, this is important because we're going to see a slice, and in that slice, we are then going to see what the structure, where it lies. Similarly, we have this as the second red plane, which is a frontal, or also called as a coronal plane, primarily because it goes through the coronal suture of the skull and then goes throughout, right? So we call this as the frontal plane or the coronal plane. Next is this green plane, which is primarily a transverse plane or a cross-sectional plane, also called as axial plane, because it goes through the transverse axis. So these are the terminologies you'll also see on the reports that you will receive from the radiology side. So that's the importance of these planes, because we can describe everything that we see of the lesion in this plane, and we can study the lesion in these planes. So this is how usually from the CBCT softwares, these are the kind of images what we can get, where we can see all these three planes simultaneously in a single image. This is called as a Mpr image. The Mpr stands for multiplanar reformatted image. Now, what is meant by multiplanar reformatted? So we are essentially seeing these three planes. This transverse plane or the axial plane is here. This is the axial plane. The mandible has been cut transversely like this. Then we have the coronal or the frontal plane. This is how it appears. So we can see that the mandible has been cut in the frontal manner. So we can see in this, we can see structures which are there anterior, posterior, medial, and lateral. In this, we can see structures which are lateral, medial, superior, and inferior. Similarly, this is our sagittal plane. This is how it appears. So in the sagittal plane, we can see things that are posterior, anterior, superior, and inferior. So essentially, when we look at every plane, it gives us 2 dimensions. But when we combine these 2 dimensions in all the 3 planes, we get all the 3 dimensions simultaneously. And that helps us understand exactly what a lesion is, where it is in those parameters that we just discussed, that is location, the periphery, the internal structure, and finally the effect on its surrounding structures. So let's take a few cases of Amiloblastoma to understand how exactly this goes about. Right? So this is the first case. Now this is a 70-year-old man. He came with an anterior mandibular swelling. Now, if you know from the literature, Amiloblastoma is usually known to occur with more propensity in the mandible. So this patient came with a mandibular swelling. Okay. Right now we don't know. Now, though I have said that this is Amiloblastoma, when the patient came, we did not know what the patient is suffering from. The patient's complaint was a swelling in the anterior region of the mandible. So a mandibular propensity in benign tumors, usually Amiloblastoma is one of the culprits, and it was a 70-year-old man. Now, literature says that Ameloblastomas usually happen from the age of 35-40 years onwards, but it is more common within the age range of 40 to 50 years. Now, this man manifested it at the age of 70, likely that he had it for a longer duration, but he managed to present to us only when he was 70 years of age. And when we took a radiograph, the mandibular radiograph, this is how it appeared. So what we can see in this, let's delineate it on the basis of the 4 parameters: the location, periphery, internal structure, and effect on surrounding structures. So the location is, it is happening in the mandibular anterior segment between the canine premolar region on the right side to the canine premolar region on the left side. It is crossing the midline, right? And you can see the shape is very irregular. Now this irregular shape, though it is a tumor, it can give irregular shape, and especially in my experience, Ameloblastomas give irregular shape because Ameloblastomas grow with differential rate of growth within the same lesion. One part of the lesion grows slower, one part of the lesion grows faster. So when this happens, there is an undulated growth which is seen clinically. Clinically, I don't have the clinical pictures of these patients, but clinically is what the clinician explained to me is the clinical picture was there was a knobbly swelling. In few areas it was elevated, a few areas it was not so elevated. And when the clinician palpated it, he felt it was soft in consistency in few areas and it was firm mostly in the majority of the aspect. So when we look at this, how is the periphery? Now, if you look at the periphery seems pretty well defined. We can see the periphery like this. So the periphery is pretty well defined. We can see that it's a well defined lesion, and we can also see there is a radiolucent line, radio opaque line, which is there as a boundary, which signifies it's a corticated margin, right? It's not corticated throughout, but a majority of the lesion is showing cortication. And then when we look at the internal structure, it gives a very classic striking appearance. We can see radiolucent areas which are of different sizes, and they are separated or differentiated from each other by radio-opaque thick arch-like septae. Now, this thick arch-like septae are very characteristic of Ameloblastoma. So now, why do these thick arch-like septae form? I'll show you further, right? So this thick arch-like septae forms because when the tumor grows in differential rate, it goes about destroying the jawbone in differential rate. So what is left, the residual bone, forms these septae. Septae means bony margins or bony outlines. So these septae are seen as thick arch-like. So what do you mean by thick arch-like? It is quite thick. I'll show you here. Now this is how it appears on the coronal sections. Now this green line, if you see, if I take a knife and I chop along these green lines, these sections come about. So this is the premolar area on the left side, right? You can start seeing the lesion here. You can also see the effect on the surrounding structures. What it has done is it has caused a very smooth but severe expansion or enlargement of the buccal cortex. The lingual cortex is also expanded, but not so much. The buccal cortex is very smoothly expanded, and the way this kind of expansion happens, very commonly we see in a very common thing. In children's party, you take a balloon and you start blowing it. Isn't this how a balloon will appear? So this is called as a ballooning expansion. What you can see here also under the inferior border of the mandible, that is actually what is seen here. So this part, when it's going down here, this is getting projected on the inferior border of the mandible. So this is a ballooning expansion of the buccal cortex. And you can see the various locules that are there. So there are different locules. Some of them have perforated the lingual cortex. Some of them have perforated the buccal cortex. So this is called as a classic multilocular appearance, a multilocular radiolucency or a multilocular appearance. And within the multilocular appearance, if all the locules are of the same size, they will be called as a honeycomb appearance. But these appear like soap bubbles. The children, when they blow soap water and create bubbles, each bubble is of a different size. So this is classically called as a soap bubble appearance. And you can see the effect that it has caused upon the surrounding structures. You can see that the teeth are missing. So the patient said that the teeth fell off on their own. So likely that the bone support for these teeth was completely lost, and the teeth became so mobile and they were lost. Right? Now this is how it appears on a multiplanar image. You can see on the axial image that how it has completely caused a large expansion of the lingual cortex, large expansion, ballooning expansion of the buccal cortex. You can see the multiple locules, the arch-like septae that are there within it. And this is how it appears on a 3D reconstructed volume image. You can see the septa. You can see it better on this image. You can see now this is a bony septa. This is a bony septa here. So these bony septae, they are very classic. This patient underwent surgical management for this, and the type was a type of Amiloblastoma. There are various histopathologic types. I'm not going into the histopathologic subtypes, but an Amiloblastoma, this is how it appears on imaging modality. The next case is of a 38-year-old man. This patient presented with an impacted 4-8, and because the 4-7 was absent and the 4-8 was not erupted, a panoramic radiograph was done, and this is what was seen. There was this 4-8 which was sitting at the angle of the mandible, and it had a lesion associated with it. So this was a large radiolucent lesion which was including the impacted tooth. Now this is again a variant of the Amiloblastoma, and what you can see in here, the location is very typically the molar ramus region, again a very favored region of the Amiloblastoma, and in the mandible, of course. And then the shape is again irregular. It is neither oval, it is nor spherical, but it is very irregular because the anatomy in this region is such. The ramus comes off at a 90 degrees or a angle to the obtuse angle to the body of the mandible, and the lesion here is spreading into the body as well as into the angle. So this is how the lesion appears. Again, we can see one ballooning expansion. We can see the periphery is well defined. I can completely draw the periphery out. We can see the internal structure. There seems to be some radiolucency here, but again, this is a 2-dimensional image. So let's go about looking at it on the 3-dimensional image. So this is how it looks on the coronal sections. So in the coronal sections, this is the buccal cortex, this is the lingual cortex, buccal cortex, lingual cortex, buccal cortex, lingual cortex. So you can see now I have traced the mandibular canal, right? This is not the nerve, it's just the canal in which I have been able to put color. So in this, you can see a slice of the canal. You can see this red dot. So the canal has been completely displaced buccally and almost to near the inferior border of the mandible. The inferior border of the mandible is expanded. The buccal cortex is expanded. The lingual cortex is expanded. And in few areas, it is also thinned out and perforated. And as we go anteriorly, this is how it comes. We can see, posteriorly, the impacted tooth is seen here, we can see that the lesion is completely engulfing the tooth, and the tooth, only the crown is engulfed. If you can see here, these are the roots of the tooth, and the tooth are only the crown is involved. So likely this developed from the follicular space of this impacted tooth, and then what we have is this large lesion that has developed, and you can see the internal structure is almost completely hypodense. Since this is a CT scan, we'll use the term hypodense, and we see that there's nothing much except for the crown of this tooth. This is how it appears on a multiplanar image. So we can see very clearly, this is the inferior alveolar canal or the mandibular canal. You can see the canal here. We can see the impacted tooth, and then there is a weird shaped lesion, but it is completely attached only to the crown of the tooth. So this was a unicystic type of amiloblastoma. Sorry. So this was a unicystic type of amiloblastoma, and again the patient had to undergo surgical management only. Now that is again the other hallmark of benign tumors. Most of the benign tumors, majority, more than 95% of benign tumors will have to be operated surgically. And for those surgical management, these kind of imaging modalities are very helpful, because it will give an idea to you as a surgeon as to where the lesion is, till where it extends, and what effect it has caused. So it helps you plan your treatment, and after the treatment is done, to follow up and see how the healing appears. This is the next case in which there was a young man who presented with swelling and mild pain, and in the left mandibular region a panoramic radiograph was taken, and now you can see the large amount of lesion that is present. Now at the age of 29, if such a large lesion has existed, it can mean two things. Either the thing is very aggressive, or it has been growing slowly for a long time. So in my opinion, I think this has been growing slowly for a long time, because as we can see that all the three molars are present here. So the molar has completely developed. After this molar has developed, then this lesion has come and pushed it. So this is where those 4 steps are very important. Location, it is present in the mandible. It is present in the premolar to the ramus region, and the periphery is pretty well defined. We can draw the outline here, and it seems to be corticated for a majority of its area, right? The internal structure seems completely radiolucent in this case, but the effect on surrounding structures is it has caused complete displacement of the second molar and the third molar. So when the second molar and third molar are displaced, they have gone completely up. So likely that the lesion started somewhere here and then started growing. So we call that as the epicenter, and from the epicenter it grows outward. When it grows outward, we can see the superior inferior thing in this and the anterior posterior aspect of this, but we do not get to see the mediolateral aspect. So for that, if we go around doing the 3-dimensional imaging, in this now we can see this is the buccal cortex, this is the lingual cortex, buccal cortex. So that's how all these sections are. So we can see the large amount of ballooning expansion that is there. It was not possible for me to trace the mandibular canal completely through and through, but you can see that probably this is the mandibular canal, right? And in this mandibular canal is completely displaced near the lingual cortex towards the inferior border of the mandible. We can see that there is absolutely nothing inside this lesion. It probably appears hypodense, or on the 2-dimensional image, we'll label it as radiolucent. So this is how it looks posteriorly. Again, the ramus has been expanded. This is the lingual cortex, this is the buccal cortex. So it is expanded completely, and we can see that there is also perforation of the cortex. So this again turned out to be another type of unicystic amiloblastoma. Now in this, the other feature that I want to show is, look at the roots of this first molar. If you see carefully, the roots of this first molar look like they have been chopped off with a knife. It's a very sharp margin. It looks like a bevel has been done. So we call this as knife edge resorption, and this knife edge resorption was seen because of this lesion. So this lesion, usually knife edge resorption is shown by lesions which are more aggressive, and they create a very sharp cut of the roots. So again, more probability of seeing this in amiloblastoma. The other lesions that I have commonly seen which give knife edge resorptions are odontogenic mixomas. Very commonly they give that. So this is how it looked on the volume image, where no septa, nothing is seen, and there is complete expansion and thinning out. Now, why I have put this particular images, again, this is a pitfall or limitation of the volume images that are seen from CBCT scans or even from CT scans. Now, as we could see in the previous sections, we can see that the cortex is expanded, but it has not been perforated. But you can see that it is completely thinned out. So this thinned out cortices, they look like this on the 3D volume images. Now 3D volume images are reconstructed by the computer algorithms. So not to go 100% by these volume images. So that's a pitfall. And you'll see that this looks like a perforation, but is not. Similarly, if you look, this maxillary sinus also looks perforated, but it is not. There is a thin amount of bone there, but there is a limitation that we see on the volume images that are reconstructed from the CT scans. Now, this is a fourth case, which is of again a young man, a 27-year-old man, and he presented actually to his dentist for just getting scaling done. And during scaling, the dentist felt that these premolars on the right side were a little mobile and asked the patient to get a panoramic radiograph done. And what was seen was this, an impacted tooth, which looked like a premolar. There was one more impacted premolar. So these are supplemental premolars because the normal set of premolars are already present. So there was a supplemental premolar, and along with it, there was a large lesion which was attached. Now this, if you see carefully, this is a single lesion, but it appears as two compartments. If you see, there is a radio-opaque septa which is there, and there is this associated impacted tooth in the mandible, in the premolar molar region. Again, a very favored area for the Amiloblastoma, usually seen with an impacted tooth, but the patient was completely asymptomatic. The patient had absolutely no idea that something of this sort existed inside. And this is how it appeared on the volume images. Now here you can see that this is showing again a perforation, but what it was just a expansion of the cortices. Both the lingual cortex and the buccal cortex was expanded, and there was a smooth expansion here. This again, histopathologically was proved to be an Amiloblastoma, but clinically when we see, this can look anything like a odontogenic tumor or even a dentigerous cyst, which can appear from this impacted tooth. Now, how to differentiate? Now, a dentigerous cyst usually will not just give such less expansion, and it will not give a differential rate of expansion like this. And odontogenic keratocystic tumor or keratocystic odontogenic tumor or an OKC will usually not show much enlargement at all. I will show you in the further cases. So this ultimately proved to be a Amiloblastoma, and you can also see that some area of this root resorption is seen, but this is not the complete picture because this was only part of the root which has come in the slice. You can see here there was some amount of resorption that was seen. Again, that was knife edge resorption. Now this is a fifth case, and this patient had already undergone an MR scan. So earlier when I was talking about the hypointense and hyperintense, so I just thought let me show you one case of an Amiloblastoma. Now this was proven, biopsy proven as Amiloblastoma, and then the patient underwent treatment. Now this patient had an MR scan done because the patient had gone to a ENT surgeon, and the ENT surgeon asked to get a MR scan done. Now in this you can see that this is where on the left portion of the jaw there is a lesion here. You can see this is how the normal jaw appears, and this is how this lesion appearing. Now this lesion is appearing more towards the black or the gray part, so this will be labeled as an hypointense appearance of this lesion. It is a well-defined lesion, but within this hypointensity you can see that there is a difference within the intensity. This appears more hypointense and this appears a little less hypointense. Again, some hypointense spots are there within this relatively hyperintense area of this lesion. And if you look at the same lesion now it is appearing completely different. So this is a difference in an MR scan. So when you're interpreting or using an MR scan, be very careful. Always consult a radiologist, because the same lesion, the first image, this which I showed, is called as a T1 image. This is called as a T2 image. Now I'm not going into the technical details of what a T1, T2, and there are various other sequences that come in MR scans, but this is how the same lesion can change appearance on an MR scan. That's why you have to be very careful that you do not interpret MR scans just similar to a CT scan. Always better to consult a radiologist and help you understand what the kind of lesion is. And this is how it appeared on a coronal section. So this is again a coronal section. Now in this is appearing completely different now, different to the hyperintensity that we saw. Look at the image which appears here. This is very severely white or severely hyperintense, whereas this it's not appearing so hyperintense, and this is appearing so hyperintense. So these are three different sequences that have been used in the MR scan. So this was again a case of Amiloblastoma. This is the fourth sequence that was used, right? Let's consider now keratocystic odontogenic tumors. This was a young woman, 31-year-old woman, and she had a posterior mandibular lesion, which was detected on radiography. This patient underwent a panoramic radiograph for her routine dental treatment, and then the dental clinician saw this lesion and then asked for a three-dimensional scan, right? We can see now in the buccolingual sections, this is the buccal cortex, this is the lingual cortex, buccal cortex, lingual cortex, buccal cortex, lingual cortex. So in this, we can see that there is a hypodense lesion, and this hypodense lesion is present. As we can see, it is going in between the roots, but not doing much problem to the roots. We can see that the roots are completely intact and it is still going there. Now look at the buccal cortex and look at the lingual cortex. There seems to be absolutely no change. Now this is again a hallmark of KOTs that we see clinically, where usually they tend to spread anterior-posteriorly rather than cause any buccolingual problems. So the buccal cortex and the lingual cortex usually do not show any manifestation, and you can see that that continues throughout. This is in the posterior region, the molar. The roots are again complete. It comes in between the roots. So there is scalloping, we can see. So it goes in between this. So this is called as a scalloped structure. Well-defined margins, but in this case, it is not corticated. The cortication that we see is the buccal cortex itself. So that's a natural anatomy that is present there. So the lesion has got nothing to do with that, but it is still having a well-defined border. And you can see that it has not caused much effect on any of its surrounding structures. The mandibular canal is present in its normal spot. The teeth roots are not affected, and the buccal and the lingual cortices are not affected. Here you can see very clearly how it is going in between the roots and it is coming. And you can see in this image and this image that the cortices have not been involved at all. This is how it looks on the three-dimensional volume reconstructed images, where you can see that the buccal cortex is completely intact. But again, like I said, be very careful while interpreting these images not to go 100% just by these images. The next case is of a 27-year-old woman, again underwent routine radiography just for the presence of this impacted 3/8. But what was seen was there was a lesion here. Again, a very well-defined lesion. In this case, you can see some corticated margins, right? And you can also see scalloping here, and you can see this. This is again a bony ridge, very commonly seen in KOTs. So this is how it appeared. Absolutely no effect on the, this is the lingual cortex, this is the buccal cortex, lingual cortex, buccal cortex. So absolutely no effect. You can see a bony ridge which is present at the lingual cortex. Usually it is present at right angles to the either the buccal cortex or the lingual cortex. Again, this is a feature which is very commonly I have seen in OKCs or KOTs. You can see now this is a bony ridge and it is going almost across, right? But if you remember the Amiloblastoma, it was much more thicker. Here it is thinner. So this is a bony ridge which is not labeled as a thick arch-like septum, and it is not dividing the lesion into locules. This is again very characteristic. Though an OKC is at times labeled as a multilocular lesion, very few OKCs I have seen come completely multilocular. This is how they mostly appear, by anterior-posterior growth. You can see the scalloping again. It is going and touching the root, but not affecting the root. You can see the bony ridge. You can see the scallop margin. At this part of the margin, it is corticated. That means it has been long-standing for quite a few months or years, right? And you can see that the cortices are barely expanded. Very minimal, if at all. This is how it appeared on the volume reconstructed image. The next case, again a KOT. This, again, the patient came with an impacted third molar and the radiograph was taken. Now I have cropped this just so that it doesn't overlap this, but this was an entire panoramic radiograph. And you can see that the mandibular canal could not be traced completely. And along with this impacted third molar, there was this lesion which was present. It was again an irregularly shaped lesion, but you can see that it is well defined. I can completely delineate it from the normal bone. You can see that the margins are scalloped, right? And you can see the bony ridges which are there, yet it is not appearing like a multilocular lesion. Let's see how it appears on the sections. Now you can see this is the lingual cortex and this is the buccal cortex. This is of the ramus. So you can see there is slight amount of thinning here, but not much expansion. And the same thing here in the posterior regions of the buccal cortex. Now, had this been, because the other lesion which can be easily confused with this is classically a dentigerous cyst, which is arising from this impacted third molar. Now, a dentigerous cyst would have created a large amount of expansion. It would not have grown just superior inferiorly and anterior posteriorly within the bone. So we can label that KOT is a little shy lesion. It does not want to go about creating much effect. So it will try to be as innocuous as possible and just spread anterior posteriorly and superior inferiorly within the amount of bone that is provided to it. Okay. This is how it appeared. You can again see the very nice scalloping that is there. And since it was involving this area, we could not determine the mandibular foramen accurately. And that's why the tracing, you can see the mandibular canal from this part, but here it was not completely delineated. This is how it appears when we look at from the lingual surface of the ramus. Now I have cut the mandible and we're looking from the patient's tongue. So again, you can see the scalloping, the ridges that are there, but it is not forming any bony septae. The next lesion that I would like to show is the Odontogenic Mixoma. So in this, it was a 41-year-old woman and she complained of a swelling which was painful. Now, if you notice, most of the Ameloblastomas and the OKCs, they come painlessly, but myxomas usually are a little aggressive lesion, and this lady had pain. You can see again well-defined lesion, and you can see there is necrotic lesion. Right? And you can see now this is the buccal cortex. This is the lingual cortex, and you can see the mandibular canal which is there within it, and you can see that there are different parts to the lesion, as we can see here on the two-dimensional image as well. So this was a multilocular lesion. It has caused expansion of the cortex as well as expansion of the inferior border of the mandible, right? And as it goes posteriorly in the ramus also, it has caused that. It has caused perforation of the lingual cortex of the ramus, and it's at the angle of the mandible. So this is an aggressive lesion, but luckily for this patient, it had not caused any root resorption. The shape is almost irregular, right? So this, when it was treated surgically, the specimen when tested histopathologically, it turned out to be an odontogenic myxoma. This is again the lingual view of the mandibular ramus and the body. You can see now, this is the way the locules are present and the bony ridges and the septae that are present within. This is a root of the tooth, but these are the septae. Now this is the second case of odontogenic myxoma. This was a 51-year-old man and he complained of swelling and pain. As is very evident, there is a pathologic fracture here, right? And we can see that there are multiple locules in this. It's here, 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 all these. Let's see how it looked. This is how it looked on the three-dimensional imaging. This is the buccal cortex. This is the lingual cortex. Buccal cortex, lingual cortex. So you can see the various locules. And very characteristically, if you see these septae which are there, they are at right angles to each other. Very classically, this is seen in odontogenic myxoma. And this is also called as a tennis racket appearance. Right? It looks like the strings of a tennis racket, and that's how clinicians have described this in literature. And you can see then this is a pathologic fracture that had formed because of this lesion. And that's what was causing the pain to the patient. This is the pathologic fracture that was there, and the cortical destruction that was also seen. These are the various locules that were present in the same lesion, well defined though, and it is corticated, yet an aggressive lesion. The next is an adenopathic odontogenic tumor. Just a couple more cases I'll be showing. So now this is not a very common tumor, and usually the textbook described this as seen in the maxilla, more favoring the canine premolar region. Now, unfortunately, my case, do not read the textbook. It manifested in the mandible, and in the mandible, it manifested not only in the canine premolar region, it extended into the anterior region and up till the molar region. So you can see that the lesion is extending from here to here. Again, you can see it's a very well-defined lesion. It has a cortical margin. Now this cortical margin is very important because I keep referring to it, because if there is a cortical margin and if it is lost, that can be one of the features that the lesion is turning malignant. Mostly or most of the times it is not the case, but it's better to be aware of that, right? And you can see that it is appearing this as one lesion and this as one lesion, but it was one lesion itself. And also you can see that there is this fine white thing which we can see here. Are you all able to appreciate it? Right? So this is something looks like a calcification. So let's look at how it looks on a three-dimensional image. So this is how, this is a buccal cortex, lingual cortex, buccal cortex, lingual cortex. That's how all these sections go. You can see there's an expansion of the cortex, and we can see that there is this fine white powder-like thing more towards the periphery here. And this is how the lesion has created expansion of the cortex, and there is also calcification within it. And histopathologically, this turned out to be an adenomatoid odontogenic tumor. Right? This is a 2 locules of the lesion, and this is how the calcification appeared. Scallop margin, but it had caused a lot of expansion. So this had to be differentiated from OKC. Now the OKC usually does not produce such type of calcifications within it. And usually OKCs are seen within the younger age range, whereas this was a 57-year-old lady. This is how it appeared on the 3-dimensional volume reconstructed images. Now odontomes usually are not classified as neoplasms anymore. They are classified as hamartomas because they have very limited growth potential and very local to that area. Now this particular patient did not have the 7 erupting. So that's why this radiograph was taken, and you can see that there is an impacted 7, but along with that impacted 7, there is this huge white structure. So this is a most predominantly radiopaque lesion associated with an impacted 2. So now you can also see that it has a radiolucent margin or a capsule to it. So this is very classically seen in odontomes, and this was a complex type of odontome. Let's see how it looked on the 3-dimensional image. You can see this is the impacted 2nd molar, and you can see the type of calcification. Now this calcification is very remnant of unorganized dental tissue. So it looks like the density is that of dental tissues, but you cannot make out any dental tissues, be it enamel, dentine or cementum. It's just an amorphous mass. It has created a large expansion. In fact, you can see that there is also a periosteal reaction. Now this periosteal reaction suggests that this lesion has been long standing, and that's why the bone has started remodeling here. You can see that there is a hypodense or a radiolucent capsule all around the lesion, right? So this is a very benign lesion, definitely. And when this was removed surgically, it was confirmed to be a complex odontome. This is how it had caused the periosteal reaction, expansion of both the cortices and the impacted tooth. Right? Now, right after seeing that case, a few weeks later, this case came about. Now, if I go about just assuming that this is a complex odontome, this is where the dilemma came about. Because this looks very similar to the previous case I showed, isn't it? The 6 is present, the 7 is impacted, 8 is not present, but you can see that this was a very young patient. She was a 14-year-old girl, and she complained of a painless swelling which was present. And then this is what was seen. So what we can see is a predominantly radiopaque lesion with a nice radiolucent capsule around it. It has caused expansion, we can see that, right? And it is corticated. On 3-dimensional imaging, this is how we found it. The inferior alveolar canal was completely displaced inferiorly. It had caused expansion of the buccal cortex, of the lingual cortex, thinning of the lingual cortex, and it was uneven expansion. As you can see, here it is more, here it is less. So all this, that led us that we need to consider in the differential diagnosis, this may not be just an odontome. This was again managed surgically, and once it was tested histopathologically, it was confirmed that it was in fact not an odontome, but turned out to be an ameloblastic fibrodontome or ameloblastic fibrodontoma. Now that is a very aggressive lesion, and that had to be managed immediately surgically. So it was managed surgically, and we found out only histopathologically. So lesions look very similar. That is the thing that I want to show with these two cases, the odontome and the ameloblastic fibrodontoma. And the odontome was just a normal lesion, not too much of concern, but of course it was causing some amount of problem there. But this, if we were left unchecked, it could have grown even more and caused a lot of problems in the growing dentition. Being a 14-year-old girl, especially if the face gets disfigured, that's a major problem to her social life, right? So what are the takeaway points that I want to give you from this talk? That the diagnosis is a very evolving process. You cannot expect the diagnosis to be given immediately as soon as a patient is seen. You have to first, like I said, give a good history taking. You have to give the patient a patient listening. Then you perform a systematic and thorough clinical examination. And then you use the adjunct modalities that are available. Whenever in doubt, always consult, because there are so many specialists available now who can give you aspects of the clinical thing, of the clinical examination, of the investigative modalities, be it imaging, be it histopathology. There are various imaging modalities. There are various other diagnostic tests that can be performed. We cannot go into all of those, but all those can be utilized. So whenever those are available, and these days most of them are available, at least if not immediately in your area, somewhere around. So please use those adjunctive tools. Those adjunctive tools give a lot of information, especially if the patient is being planned for a surgical modality of management. And the most important thing to do is not to panic. Now, why do I tell this? Because I have faced this. Like there were few of these cases in which the patient underwent just routine radiography. And as soon as the radio, now some of the clinics have their own panoramic radiography machines. They got the radiograph. One of these cases, for reasons of privacy, I cannot divulge which one, was a Bollywood actor. Now, as soon as the Bollywood actor got the radiograph, the technician saw and gave a panic reaction. Ooh, itna bada kuch hai isme. Now, such a big lesion was there. The technician panicked, then the doctor panicked, and then the actor panicked. There was panic all around. Of course, there was a lesion. It was treated surgically. That actor is very successfully acting right now in films. All that happened, but that created so much panic. The actor went berserk for 2-3 days. That actor didn't eat apparently, and all that because that was seen. We did the imaging. The surgical line of treatment was advised to the patient. The patient underwent the surgery, but it caused so much problems to the patient. So not to panic when big lesions are seen. You remember these lesions when they are seen, and then consult and undergo the adjunctive tools that are available to you and find out what it might be, and then go about doing your surgical line of management. Because primarily the focus has to be on the patient, like I mentioned at the outset of my talk, and not just the lesion. Focus that the patient is a live human being, an individual with emotions. The emotions get affected. Nobody wants a disease. But when there is a disease, it will have to be taken up. And yes, many diseases have to be taken up surgically. So you will have to focus on the patient, educate the patient that there is a lesion there, consult the various specialists that are required, and then go about doing your therapy there. Right? I would like to end my talk here. I would like to thank the Department of Oral Surgery for giving me this opportunity.
Better, right?
If there are any questions, probably we can take it now or later. Dr. Benign, how do we go about it?
Discussions we'll do in the panel discussion, sir.
Panel discussion. All right. So I will stop it here. If you have any further doubts, you can email me at this email ID, right? But most of the cases are classic, what I have shown, and some of them are B. Right? So I will stop here. Thank you so much.
Thank you, sir, for your wonderful, thought-provoking presentation. I'm sure many would have, and especially the postgraduates, benefited from your lecture. Thank you once again, sir.
Thank you.
All right. We will move on to the second guest lecture now. Let me have the privilege to introduce He's the head of the department
My Miss, can you hear something? No.
Sorry for this microphone is off. So let me have the privilege to present Dr. Swamithan, sir. He is the head of the Department of Maxillofacial Surgery, Government Dental College, Calicut. He's a very dynamic personality. He was my HOD during my college days when I did my PG from Government Dental College, Trivandrum.
My picture is not coming.
way back in 2005. So let me introduce him now. He did his undergraduation from Courts, Manipal in the year 1989 and post-graduation from Government Dental College, Calicut in the year 1996. He is in the government service for more than 30 years now. He has many national and international publications in peer-reviewed index journals. He is a regular keynote speaker in state and national conferences. He is also a former Dean of Dentistry in Calicut Varsity and also the PG board member of Kuhas University. So let me present you Dr. Saumitran sir to deliver the guest lecture now. Over to you, sir.
Hello, good morning. Is it, I'm audible?
Yes, sir. Yes, sir. Clear.
Yeah, fine. Okay, yeah. Thank you so much for the kind words, Dr. Vinay. Let me also tell this morning to wish Professor Akhtar Hussain and Dean of Yenepoya and Lakshmikant Chhatra, who was my colleague and batchmate and HOD of oral medicine there, Dr. Joyce C., HOD of Maxillofacial Surgery Department, Professor, Dr. Subhash Chandra, and my co-speaker, Dr. Ajay Naik, and all the participants and faculty members who have attended this program. So we had a lovely presentation by Dr. Ajay, who already told you about all the issues of diagnosis and how to read up the imaging and the modern things about that, how you can assess the different tumors and the characteristic features and many things. So I'll be mainly touching upon the management aspect, and I'll be, of course, covering up a little bit of pathological side also. So as we don't have a pathologist panelist in this group, so I just tried to cover up and tell some of the points of their views also. And here I'm going to start with the surgical management of benign tumors of the orofacial region. So the topic is given as orofacial region. I'm but sticking more to the jaw tumors because it's a very huge area of topic to cover the entire orofacial region things. So I may not be going to the skin cancers and or the benign things or salivary gland tumors. I'll be mainly touching upon the odontogenic, non-odontogenic things and certain things which is coming in and around while my presentation is going on. This paper comes to you from the city of Calicut. And you can see the medical college on the background and our dental college from which the paper is coming. And when you come to this orofacial region tumors, in the case of the jaw bones, maxilla and mandible, one should know that it is a site for a multitude of neoplastic conditions. Okay, and odontogenic tumors, especially, was a heterogeneous group. Okay, and to the different degrees of intertissue interactions and various growth patterns. The interaction between the mesenchymal and epithelial components, and this goes on right from the 4th and 5th intrauterine life to almost 19 years of 16 years of age of the patient. So during this large span of years, a lot of things are happening in the development and growth, and this has led to a very many number of cases. And we usually say tumor neoplasms and hematomas and malformations. But basically, you can put all these things together, and we call it as odontogenic tumors. So we have to talk about hematomas and malformations and neoplasms when we talk about jaw lesions. So you have the categorization, you have cystic lesions, odontogenic tumors, in which you have benign and non-odontogenic tumors also, the malignant tumors, and the diseases of the bone. The malignant tumor and the other malignant lesions I'm not covering here, because we'll be sticking to the benign lesion management only. So our diagnostic workup is the most important thing. How do you come to a diagnosis? Ignoring or delaying a diagnosis does not change it. So it's a meticulous workup of your patient, right from the history, your clinical examination, and imaging. Now you have a lot of equipments and methods. Before we managed with just X-rays, you had just an IOPA or an OPG or a maxillary sinus PNS view alone. When you look back, the management things in 60s and 70s and all. Later on, the scan, CT scan has come, and all the angiograms have come, salivary silography, MRI, and PET scan, and such a huge expanding field, and so much of information is in hand nowadays. And biochemical profiles, that also have come up in a big way. Many other newer investigations You don't have to do all the investigations required for any case. You do the required ones only. You have many sophisticated investigations. Those which are really mandatory and must be used, you have to do. Many of the centers like government colleges have limitations in going for high-tech X-ray views and biochemical profile things, which is really a problem for our research and patient management also. To some extent, will be affected because of lack of facilities also. Countries like India will have a problem, even though we have come up a long way in tackling it, but still we have a problem. Of course, then coming to biopsy, which is of course the one which will give you the final diagnosis of your case. Now, imaging, I am not touching upon that. Dr. Ajay has told about most of the things. I just have to put a slide here to show the role of them in the management. Just put a picture of all scans and bone scans, PET scans, and MRI, and how you detect a hot lesion in oral cancer and all. It's gone a long way in the management of patient, and the prognosis has improved a lot because of all these things. Now, coming to the pathologist role nowadays, it has really transformed in the last 2-3 decades. Before, there are things were only that pathological, histopathological picture, which we have to rely on, and that is still useful in most of the cases, but they have really come up with immunohistochemistry studies and molecular biologies, flow cytometries, and electron microscopes. Now we will be, instead of an objective kind of a subjective kind of a field, it has really become an objective kind of a field, maxillofacial pathologist. And we are looking forward to them as a surgeon for many of the help nowadays, and they are in a position to dictate your treatment also, because it has come up so much forward. And nowadays all this immunohistochemistry stuffs and all, we are doing it, but not in all the kind of tests is mentioned and all because of the cost and all, but really very good informations are coming on that. So immunohistochemistry, these are some points. Nowadays we are getting Ameloblastomas express cytokeratin 5, 6, 13, 14, and 19. So that is a very evident thing in your diagnosis also. Mixomas, again, you can have some clue about that. The proliferation rate will tell you the indicator of malignancy in Ameloblastoma. The pan-cytokeratin markers confirms the presence of odontogenic epithelium, or in epithelial poor odontogenic fibromas. Like that way, a lot of information is on coming with immunohistochemistry, and we make into consideration all these things when we plan our treatment. And it is a former by Robert Marks, an old quote: "A best chemotherapy for odontogenic tumors is a jar of formalin." The decision comes from the histopathological picture, which is really going to change the entire course of the treatment. Now, what are the goals of the treatment of jaw tumors? Generally, we follow certain rules. Our first and foremost thing will be the complete eradication of the tumor. Okay, that is the most important thing, especially if it is an aggressive one or a high rate of transformation into malignancy and all. You don't leave behind any of your tumor or pathological tissue in the body. Your aim is to completely eradicate the tumor. So sometimes the aesthetics will take a back seat when you go for a wide resection, remove the tumor. But you can't help it as far as the tumor has to be eradicated. You have to sometimes choose one radical treatment. Now you have to preserve vital structures. For example, a lesion is coming. Nowadays, we get a lot of mucormycosis cases in our setup after the COVID, post-COVID scenario. And most of the time, the eye is the one which will be lost in many cases. So you are trying to your best to, once the eye is not affected, you'll try to preserve it somehow. So say like that way, the vital structures and saving a nerve, inferior alveolar nerve, if possible, don't include in your resection, which will produce such a troublesome numbness in the post-operative period. Same way, you try to preserve all the tooth buds in a child, because you are losing the permanent tooth forever. So such things should be taken into account. Now you have to exercise with least morbidity and facial region. Already Ajay has mentioned that is the most important area, because it's a person's personality and is psychologically crippled when you hit a facial deformity. So the surgeon has to be really giving some importance to the aesthetics also when you're operating on the face. Restoration of form and function. Nowadays, all surgery comes along with the reconstruction. If possible, most of the cases will be done primary reconstruction on the same operation day itself. The patient wants to walk out of the operation theater with his mandible reconstructed, with his missing teeth replaced, with the nose in position, the eye in position. So the best possible thing. is given from the team of people who are operating on the patient. There will be a reconstruction team ready, and if it is primary reconstruction, we have many advantages. And sometimes we don't do a primary, we go for a secondary, and the reasons for that, which I'll be covering up. And of course, the last most important one is the long-term follow-up. This is very mandatory for, especially for troublesome lesions like amiloblastoma and mixoma or Odontogenic Mixoma and things like that. You should always see that the patient comes to you every 3 months or 6 months, and every 1 year you do there the role of the radiologist comes again. He will be really able to read the lesion, whether it is recurring, any early beginning of any lesion, any again starting of a lesion, even nicely nowadays can be diagnosed by our radiologist friend. Before we just depend on an X-ray, and you may not be able to catch a recurrence. Nowadays we have these devices, and much more precisely recurrences can be detected. Now, classification, we have many classification when we study in our BDS class itself and oral pathology. We know Thomas classification, great contributors, Garlin and Pinbock, we have lesions in their name. They are pioneers in the field of oral pathology and surgery also. And Kramer and Shear, 1992, that was a very classic classification of jaw tumors. Now WHO are always having their symposiums and modifying and adding and deleting, and this is going on with the new informations. You have the 2005 WHO one, and the most recent was the 2017 one by WHO. So I'll be just going through the classification just to get an idea. Classification should not confuse you. You just have to put it in groups that it is easy to have an idea of what is the lesion and how to go about. So I'm not putting all the classification. I'm just going through the 17 classification. There will be difference in opinion about all these classification, but for the persons, for the benefit of the postgraduates, I'm just sharing. Epithelial one, you have typically amiloblastoma. You have the unicystic one, extraosseous peripheral one, metastasizing ameloblastomas, which you call it as malignant ameloblastoma, squamous odontogenic tumor, and pinbox, the calcified epithelial, and the adenomatoid odontogenic tumor. And to the mixed one, you have the ectomesenchyme also acting along with the epithelial things. You have the ameloblastic fibroma, the odontogenic primordial tumor, odontoma, again compound and complex ones, and dentinogenesis ghost cell one. Then you have the ectomesenchymal purely origin ones, that is a odontogenic fibromas, myxomas, cementoblastomas, and cementoossifying fibromas. And again, non-odontogenic, they are put just like this in a very simple way of putting into two classes: chondroma osteoma, melanocytic neuroectodermal tumor, chondroblastoma, myxoid fibroma, osteoblastoma, osteoblastoma, ossifying fibroma, elasmoplastic fibroma, fibrous dysplasias, cementoosseous dysplasias, osteochondroma, CGCG, peripheral giant cell granuloma, cherubism, aneurysmal bone cyst, simple bone cyst, and solitary plasmacytoma. So you may find fibro-osseous lesion classification. You may find diseases of the bone classification like that. You may see a little bit of differences here and there, but fundamentally we put it like this for the sake of easy understanding and for clarity. Now again, general principles. I told you what are the things, biological behavior and potential of a tumor. This is a very significant thing. Still, we have not much clue in all the lesions. How a lesion behaves sometimes is very tricky. You get adenomatoid odontogenic tumor, which is usually encapsulated, and very easily you can patient comes with adenomatoid with a very aggressive growth, very aggressive with the destruction of so much bone and rapid increase in size. And biopsy report comes as adenomatoid, but so something else is playing there. Same when ameloblastoma, you get an ameloblastoma, ameloblastic fibroma, for example, which is much less troublesome compared to our routine ameloblastomas. But sometimes we use an ameloblastic fibroma recurring after removal. So we do a conservative treatment and we see recurrence of ameloblastic fibroma. And those recurrent ameloblastic fibroma, we see 40% going for ameloblastic fibrocarcinoma. So what are the factors playing again? The biopsy report is ameloblastic fibroma, okay? You have done a conservative management. Recurrence also ameloblastic fibroma. And you see, very surprisingly, 40% go into ameloblastic fibrocarcinoma, okay? Recurrence is very low, but once recurred, malignancy is high. So in which one, what are the factors playing here? That is where the immunohistochemistry role comes nowadays. And there's much more evidence is coming now. and things have been identified, oncogenes have been identified, and maybe within the ameloblastoma, within the histological pattern, you have still some more classification or varieties coming up, which will tell you this could be aggressive, this could not be aggressive, this will turn into malignancy, this will not turn into malignancy. So this is the challenging thing and everyday changing speciality of a tumor. Okay, so the potential of a tumor is very important for a surgeon, whether to go radical or whether to go conservative, whether to include the lymph nodes, whether to give radiotherapy post-operatively. So in oral cancer also, these are nowadays coming up in a big way. And growth characteristics of a lesion have to be studied, whether it is very rapid, okay, and most of the very rapid things we consider it as malignancy. But see, some of the benign ones having very rapid one, central giant cell granuloma. Suddenly it sprouts out and comes like a sarcoma. And the biopsy report will be odontogenic, a central giant cell granuloma. And hyperparathyroidism person may come. Suddenly you see a huge lesion, proliferating one. You take a biopsy, you rule out CG, and the diagnosis comes as hyperparathyroidism. When you look at parathormone level or serum calcium level, and you see adenoma of the parathyroid. So sometimes you don't have to jump into the diagnosis. You need a much more investigations. Anatomic sites are very important. We'll come to that. Clinical extent and site of tumor, another factor. And of course, the histological assessment. Now, it is always a teamwork when you treat a tumor or a cancer or whatever it is. We have the diagnostic people, the radiodiagnosis man helping us, the maxillofacial pathologist, max fac surgeon, other reconstructive surgeons. Sometimes if it is a cranial involvement, a neurosurgeon comes. Certain strange lesions like osteoporosis, pediatrician comes, and ophthalmologist come. So many people comes, and it is a multidisciplinary approach, and it is decided around the table, and the best possible management is given. So planning of a management of a odontogenic tumor, how you will plan it? These are certain factors: the location of the tumor, the size of the tumor, and whether it is confined within the bone as it comes out of the bone. As Ajay was mentioning, how do you know a cortical bone is perforated and it has come out, and how far it has gone, which are the structures involved. Now they will tell you the muscles are involved, or they can tell you the nerve sheet is involved. Okay, much more precise to locate the exact position of the tumor. Aggressiveness, as already mentioned, proximity to vital structures, involvement of bone, what are the reconstruction methods you are going to choose, and what is the patient's choice. That is also very important. Sometimes an 18-year-old girl will come with an amiloblastoma. She said she's not interested in resection. The treatment is resection, but the patient don't want resection. Okay, such thing comes. You may have to come to a consensus. Maybe you have to tell her that we will go conservative, but with a very strict regular follow-up. If at all something happens, we may have to resect in future because she is anticipating a marriage. So she's traveling to somewhere, or he is traveling somewhere. He wants to do the surgery after 2 years. In such times, we will consider that and don't go for a radical one. Wait for a conservative approach, and later, when the patient is much more prepared, we'll come and go for a radical treatment. Because on the face also, it is not very easy to tell all the treatment, but difficult for the patient to accept. Now, good judgment comes from experiences, and a lot of this comes from bad judgment. Now, this is one of my lesion which we have operated in Trivandrum. This has got a maxilla and the mandibular involvement. Okay, so the case is a vicious one. The biopsy report was amiloblastoma. Now look at the location of the lesion. It is coming just closer to the orbital area, going into the temporal area, going up like that, and in the posterior area of the mandible, the ramus area. Of course, the medial wall of the mandible will be also affected. So this location of the tumor will decide. This is going to be a little wide resection, and many of the vital structures are maybe included. Or you cannot just give a very super conservative management here in this case, because you may end up with a intracranial extension of the tumor very soon. You cannot leave behind a tumor here when a patient comes like that. You have to go for a wide resection. It's an amiloblastoma. Otherwise, after 6 months, the patient will be going to a neurosurgeon with some other problem, and they may detect a malignant, amiloblastoma of the cranial cavity within the cranium, and it becomes inoperable. Now, size of the tumor, again, I was mentioning whether it is confined within the bone, does not come out of the bone. Okay, it's limited there because of the natural protection, and it is contained within. And you have good news then, you can just remove the bone and get away with removing the overlying mucosa, or you don't have to go for a wider one. Okay, so the confining within the bone will be a good news. Once it comes out of that, you have bad news, especially aggressive benign tumors are coming. Now you look at the tumor aggression, a patient comes like this. This lady came with a swelling like this, and it was not a very fast growing one. She was having this for the last 15 years. So that shows that it is not that aggressive. 15 to 20 years she's carrying this. Slowly it just enlarged. Okay. So this will be the clinical picture for a malignant one also. The patient may come to you and had a swelling like this. When the swelling started 3 months back, then that is a very ominous news. This could be definitely a very aggressive one. It could be an osteosarcoma. Okay, it could be a fibrosarcoma. The clinical immediate look give that picture. Of course, the patient will be very cachectic, weak, and all those things are there. Okay, leukemia lesion will come like that with a sprouting of gingival growth like that. But sometimes a central giant cell granuloma will show like this. Okay, so that's the tricky thing about all these things. How do you don't jump into that? Go for the biopsy, get all investigation, and rule out. Or hyperparathyroidism will show like this. Now, reconstruction, as I already told you, you have to choose for the primary or secondary. That decision has to be made. And there are many factors considering there. What is the primary reconstruction you're going to do? Or are you going to delay this reconstruction for a later time? Now, the terminologies, when you come to a surgeon, these are the basic few terminologies. Among the surgeons, we use it. We can use the word enucleation, curettage. Everything is defined. What is an enucleation is defined. What is curettage is defined. Marsupialization, recontouring, resection without continuity defect, with continuity defect, disarticulation. Okay, I will tell you what is each and where do you do it. You have a wide range of these procedures which we use according to the case, tailoring according to that. We will choose the procedure and we have an explanation why we are doing that. Now, an en bloc resection, here you can see a lesion here, you can see a tumor here. Look at that patient, and maybe it's a big, huge amiloblastoma or an aggressive tumor where you need to remove some normal bone also along with the tumor. This is not a periapical cyst, okay? If it is a tumor, okay, if it is amiloblastoma, I'm not telling you the malignant one here, benign one itself. You see the bone remaining here. It is just less than 1 centimeter in thickness, a pencil thin mandible lower border. You can't retain that lower border. During the surgery itself, when you are taking a 1 centimeter normal margin of bone, which we usually do in amiloblastoma, you can't retain the lower border. You have to take it out. You leave that because the extension of the tumor will be there, definitely into this. We have studies to showing extension of all the tumors. So we have evidences, in which case, how much margin has to be taken. So on that basis, we'll say, you better not retain this here. And what happens is sometimes, you will end up here. Yeah, you can have a pathological fracture. You do a resection, leave a very thin pencil margin. In 2 weeks, 2 months time, they'll come with a broken mandible. So you tell the patient right in the beginning, when you remove, there will be definitely, you have to go to resect the mandible here and you have to reconstruct. You can't take a compromised stand there if it is an aggressive tumor. This is something you have to be very careful because next time it has gone somewhere into the confinement of soft tissue and all and becomes inoperable. So this is how you choose whether to retain the lower border or not. This is a periapical cyst. Of course, you can retain. Just remove the cyst, which can be enucleated out. Okay, leave some bone grafting and all. You don't have to include that no recurrence is expected. It's a periapical cyst, or it is an odonto. You can try to preserve the lower border, but it's amiloblastoma. Don't do that. Odontogenic Mixoma. Don't try that. Okay, or anything which is very innocuous and not damaging one, you can think of keeping the border of bone or something which can be spared. So that is the decision making. Here you can see you have decided to resect out the segment. You cannot no way save it. If possible, any other thing which can be preserved will be preserved by the surgeon. This decision is taken after thinking a lot, taking a frozen section, confirming that the tumor is completely removed. That is very important in onco surgeries and aggressive tumors. Now, again, planning for the resection margin. Exactly, that was the thing I was telling. This is a lesion here. If it is a dentigerous cyst, okay, it is not going to recur that easily, or it is not going to create problem for you. But it is an amiloblastoma, okay? It is a, what you call a myxoma, okay? Any kind of an aggressive kind of tumor, okay? Then what you have to think is when you are taking how much margin you will include. How much normal bone can be included in this case? That is the question. Consider this as an amiloblastoma of a what you call follicular type multi-locular. You won't see a multi-locularity here, but in the scan, if it is multi-locular, this tooth you cannot spare. You may have to include because when you take a normal margin of 1 centimeter of bone from the edge of the lesion, you're clearing the tumor. The tooth has to go. Okay, so take 1 centimeter more. The linear margin of the bone is taken in all directions, on the lingual side, on the buccal side, on the inferior border and the superior border. Everywhere 1 centimeter linear border of thing is there. We have done our own studies also. I'll show you that. So what you have to do is, you cannot think of preserving one premolar here or one canine here or things like that. Okay, you have to remove the thing so that it is completely taken off the patient's body. That is very important. Then still you have to do the follow-up every 6 months and for a long period. Okay, because very tricky lesions are these kind of things. Take out that bone piece and you send for a histopathological study to rule out. You have taken out the normal bone on all sides. That is also mandatory. Now you have the devices and imaging techniques that will specifically tell you, yes, the tumor is cleared. And then, of course, you got a reconstruction plate, but that much is removed in this case. Okay, 1 centimeter normal here and normal there is removed. The tooth is removed, all area it is covered, and initially a reconstruction plate is given. Okay, that is how we decide where to resect. Now coming to again, these are basically fundamentally we have this in our mind when we get Amiloblastoma or Mixoma, CEOT, and Odontoameloblastomas. Usually we go for resection, or including a 1 centimeter normal margin, 1 to 1.5 centimeters is adequate. Now this is evidence. This is evidence-based surgery. We are doing 1.1 centimeter because that is needed to clear this tumor. We have hundreds of thousands of cases of common lesions, but unusual lesions, you have no evidence. That's a problem. But these are very, very usual lesions. Every month we get 2 or 3 ameloblastoma or these kind of thing in our department. Every month 1 or 2 cases. Now it has come down, but certain regions you are well known to have a lot of odontogenic tumors. And in our side and our southern India part is very much known for Chennai or Andhra or Kerala or all this. Many of these odontogenic tumors are there. We have adequate evidence. I have my own evidence for 2 or 3 decades, and I know you need 1 centimeter margin. We have got long follow-up, 20 or 25, and you know what happened in cases where we went conservatively. Now these things, we can go for conservative one, an odontoma, an ameloblastic fibroma, okay, and a fibroodonto, squamous odonto, odontogenic fibromas. These usually are managed by, you can just enucleate it out. You can see a capsule around it in some cases. It is absolutely no problem. Maybe you can apply a Carnoy solution on that margins. You don't include a 1 centimeter or not even a 0.5 centimeter. But we are, of course, following up them also. As I already said, sometimes some of them produces a very aggressive ones. Even though that is the dictum, we go by a conservative one. You can expect very low percentage, but definitely a small percentage. Now, malignant, of course, you have to go very wide resection, neck dissection, as per the case, histological pattern, and the lesions are completely differing. And a lot of protocols are there in cancer centers. Such patients with malignancy has to be done in case centers exclusively where you have all kind of multidisciplinary approach. Now coming to our classical lesion, that is ameloblastoma. Okay, this can be kept as the one main guideline in odontogenic tumors. So this is the one most common and well studied, and most of them are treated like ameloblastoma in the aggressive ones. So just look at ameloblastoma, and I will tell you on the guidelines of ameloblastoma how to go about. Typical pictures, you have different varieties, 5 or 6 histological types. We have always looked whether any particular one is aggressive, and some information sometimes, some paper you see, the granular matrix type of ameloblastoma, the granular one is more aggressive, and more malignancy seen in granular type of ameloblastoma. But again, some paper says it is not correct. Granular may not produce that much. The plexiform produces. So it is controversy all over there. And granular, sometimes we also see in some of the things also. So we sometimes believe that ameloblastoma granuloma one will be aggressive, but really no great evidence for all these things. But that the debate goes on. But immunohistochemistry and things like that now going to start play a big role in these things. Now Robinson's typical classification, we all mug it up when we have videos. It is non-functional, unicentric, intermittent in growth, and anatomically benign and clinically persistent. That is a problem. This is clinically persistent. It's never going to leave the patient. You keep on, you do a conservative approach, definitely it will recur. Never do a curettage. You will do curettage or simple things only when things like a patient not medically fit for surgery or because of real personal choice, we don't want to have a radical treatment, something like that only, we'll compromise, otherwise not at all good choice, because we may produce seeding of the tumor and you have a lot of Amiloblastoma reported in the lungs, which could have been because of the scraping and curating and dropping the tumor things everywhere, pushing into the lungs through the aspirations, and you're getting a Amiloblastoma in the lungs, which will be noticed only after 20 years of your first surgery. Okay, so that's the danger of these lesions. Now, true neoplasm of enamel organ which does not undergo differentiation to the point of enamel formation. That is the classical definition. It is one of the 1% of all tumors. 9 to 11% of all the odontogenic tumors are ameloblastomas. 80% it is in mandible. Okay, I'm not telling about every lesion because ameloblastoma is a classic one. So it is 60% of all odontogenic tumors in India. 60%. Mean age is 30 to 35 years. And carcinomatous transformation 1.79 in 10 million. The problem is not carcinomatous transformation. The problem is the persistence of the ameloblastoma and going into other areas and spreading into the brain and lungs and other areas. That is the problem with this ameloblastoma. Overall survival rate is C17.6. If the patient very regularly comes for follow-up, the surgeon has done the treatment in the right first appointment itself, nicely followed up, this will be definitely 30 years or 40 years instead of the 17. Now, variants, very interesting lesions of multicystic, clinically we have put this for our easy understanding and management. Surgeons, we usually follow these three classic variety: unicystic, multicystic or solid. Then you have sometimes very rarely a extra-osseous, what you call a peripheral type. And some malignant subtypes, which can be considered in the malignant category only. So we have what is a unicystic one, what is a multicystic one. Okay, multicystic is the most common. Unicystic very rarely we get, and sometimes we miss it in the diagnosis. I'll tell you what is happening. Extra-osseous is also rare. Okay, that's the thing of ameloblastoma. Now, a unicystic again is a very histopathologically closely diagnosed one. Okay, when Robinson and Martinez, they are the one who actually really studied unicystic ameloblastoma. Okay, and they have put it as two, typically 3 lesions. That is the luminal, the intraluminal, and the mural. Mural is the most aggressive. I'll tell you why. Okay, so different proliferating potential exists between different areas of a unicystic ameloblastoma. This is a very important statement you have to look for. So if you look at these are the typical histological picture of a mural ameloblastoma or a unicystic one. Usually what we get is, it is contained within the lumen of the cyst. Okay, it is within the lumen of the cyst. Absolutely no problem when you remove a cyst and all. Okay, this is contained within the cystic wall. But intramural, it is slowly started coming into the connective tissue level, in the fibrous area. Now transmural is again slowly coming into in the margins of the cystic lining, and invades out of the cystic lining outside the capsule into the tissue around the area. So now what happens here is usually these are seen when you look at a unilocular radiolucency, typically comes in the third molar area. Okay, this is how we get it. We get an impacted tooth and the radiolucency like this, a unilocular, clear unilocular lesion. Definitely here, what is your diagnosis? Definitely you say it's a dentigerous cyst. It could be everybody's first choice of provisional diagnosis, a dentigerous cyst, yes. And a surgeon, definitely for a small one, may not go for a biopsy. If at all, he goes for a biopsy, take a biopsy from this area or this area. Okay, 2, 3 small lesions, there is not hardly anything to take an incisional biopsy itself. It will be less than 2 centimeters in dimension. Okay, but still you may take a biopsy from here. The report comes as a cystic line. That's all you're going to get. Now, you have removed what was the treatment plan? Removal of this with the impacted tooth. You just enucleate it out. It comes like an enucleated cyst along with the tooth. Now you send this to the pathologist. There you have to be careful. You send this to a pathologist. With the pathologist, you have to specifically tell. That is why you need a lot of communication between them. Tell them to look for the entire lining when they're examining. The entire lining has to be checked, because you have unicystic ameloblastoma in your mind. That's the thing. And the pathologist will find this kind of a ameloblastoma changes in somewhere in this area. Then only you know that it is a unicystic ameloblastoma. Otherwise, you think it is a dentigerous cyst. And some surgeons, what they will do, they will just throw this into the bucket. They'll remove the impacted tooth or the cystic lining into the bucket, and they will not send for biopsy. That's the problem. You will not send for biopsy. This is a great mistake you make. Any tissue in the surgical site you're getting, any granulation tissue or thing you're getting has to be sent to the pathologist. You will send that, won't send this, an important diagnosis is lost. He will come back with a bigger amiloblastoma lesion very late, 10 years or 15 years later, with the expansion of the mandible from this lesion. So because what are the type of unicystic amiloblastoma there? You should have got away if the thing was intraluminal. But unfortunately, the tumor was what you call mural. You have removed the cystic lining, the mural one already, the amiloblastoma cells has crossed into the marrow of the bone. You have removed the cyst and not sent for biopsy. The cells here proliferating and lead to a larger lesion which you will not notice. So send the unicystic this kind of single unilocular teeth lesions, anything sent to the pathologist, especially third molar ramus area. You have a suspicion of unicystic amiloblastoma. Okay, better make it mandatory and see the entire lining. You may see the, but that is why you send multiple sites for incision biopsies. One area will show you squamous papilloma. Other two areas will show you squamous cell carcinoma. Okay, one area will be moderately differentiated. One area will be poorly differentiated. So the pathologist's role and how closely they have to watch is the key for treatment of any pathological lesion. Okay, that is the rule for the orofacial tumors also. Now, peripheral amiloblastoma, again, it comes as a peripheral growth like this. When you get a case like this, you can tell it is a peripheral giant cell granuloma. It is a epilis, what you call a pyogenic granuloma, or it can be a peripheral giant cell granuloma, or it can be a peripheral amiloblastoma. You get it every result from the pathologist. They will tell you what is it. And a basal cell carcinoma always resembles amiloblastoma, peripheral amiloblastoma in the histologic picture. If the pathologist is not very familiar with both, he may miss a basal cell carcinoma. That's a tricky aspect. That is why the role of a maxillofacial pathologist they evolved into that, and that is giving a lot of information from them now. Now the management of principle I already told. How do you manage? Often treated without biopsy, multiple biopsies needed, careful radiographic examination, curettage discouraged. This is the reason for that, because you may leaving out some intraluminal or the mural kind of an amiloblastoma. Find out that there is no satellite, which is there. Okay, absence of satellite is physical integrity of wall and negative intraoperative frozen section. These things, this intraoperative frozen section is a very mandatory thing nowadays. You make sure that everything is cleared and you have the normal tissues on all sides of the tumor. Now, again, specific multi-solid, multi-cystic, the one common one is a very tricky one. A lot of things have to be discussed in the management of that. The excision, usually this is what we followed, with or without continuity defect in lesions, and involves superior and inferior diameter of the mandible. Inferior alveolar nerve can be sometimes has to be sacrificed, but some people say it can be retained because the nerve sheath is not usually penetrated by the amiloblastoma, but you have to make sure that the nerve is not involved. Otherwise, retaining the nerve will be a very disastrous procedure. Okay, sometimes I have seen many people operating without removing the inferior alveolar nerve. Just remove the cortical bone and or lift up the inferior alveolar nerve, remove the tumor, leave the inferior alveolar nerve there. But again, the question is, can you leave the inferior alveolar nerve? This is a question to be undergoing a lot of debate. So resection should be exterior to the tumor. Okay, exterior to the tumor involved. The tumor has gone to the masseter, yet the excision should go over the masseter. You can't leave the masseter completely there. If it is over the lingual mucosa, you have to clear the internal mucosa also. Okay, if it is on the periosteum, you have to excise the periosteum. Okay, so that next border of the tumor has to be removed. Otherwise, you are leaving behind the tumor mass. Use sharp cutting instruments. Make sure that you make a clean cut when you are cutting the tumor. You are not leaving behind any chances of leaving a tumor there, and repeated scraping with the burr and cutting, you will be seeding a lot of tumor there. So immediate reconstruction if possible, and maxillary lesions are much more aggressively treated because it is in a very dangerous area. Posteriorly, it can go to the infratemporal fossa. Superiorly, the orbit will be involved very soon. So in maxilla, even when maxillary sinus is involved, what we usually go for, we go for a partial or a complete maxillectomy. We cannot spare the maxilla there. because you cannot be able to delineate the margins of the tumor. Now, general principles, tumor infiltrate the cancellous and cortical bones also, and the lesion microscopically infiltrate beyond the tumor bone interface. Now, this tumor bone interface is very beautifully studied by the radiodiagnostic people. Dr. Ajay was talking about that. He's in a much more better position to tell you about the tumor bone interface. That is where the surgeon is also looking forward. He can clearly, with this new advance, tell us, okay, you're cleared of the tumor now. That gives a nice picture compared to our old and lateral oblique view of the mandible, which will never give you a satisfactory thing of your margin, or your OPG will not tell you that. And you have now contrast CT and all those things, and all the recent things, they will specifically tell all the cuts, and he has mentioned, shown you all the volume of the thing and the perforations. That is a very good information for surgeon, and which gives the very good result in the management of tumors. And we are using everything possible nowadays to get a nice management. Now, resorption of permit growth to the periosteum into the soft tissue. Peripheral connective tissue may appear like a capsule, and this may give you a false picture that is nicely covered all around, and you will think that, I have removed the tumor. But you have to make sure by a process section and know that you have cleared it. Now, conservative management, I told you, is there any role for a conservative management in Amiloblastoma? I would say no. But if at all you do, that is mainly for the patient compliance, or the patient, this patient has got MI. Okay, he's an MI patient, he had MI for the last 2 MIs and a very seriously sick man. You cannot take him for a large procedure under GA. So in such cases, only we go for a treatment with a little conservative approach. Definitely, it is not going to give you the result, but special situations. A patient doesn't want to lose his mandible. He says, I don't want to remove my mandible. I want to live like this. You take whatever possible there, recurrence coming and dying, it's not a problem for me, but don't remove my mandible. The patient will tell you. Some patients, you suggest chemotherapy. They say, I don't want chemotherapy. I know one of my professor who refused to take chemotherapy in medical college said, I would like to die like this. I don't want chemotherapy. Okay, so it is a personal choice. You can't help it, The patient's mind will have many things in them, and you can't control, or you should not. You should discuss with them and convince them. If not convinced, you can think of this. Tell them, I'm doing a conservative thing, but this is not the treatment. You have to do regular follow-up, but definitely you may need surgery in future. So, and here we can, I'm showing a slide here to do a lesion here. Here we can still think of a conservative approach if really needed, because it is the anterior region of the mandible. This is a safe area compared to the posterior ramus area. Amiloblastoma here is a safe area. There is no vital structures close to the anterior mandible. Okay, you can get away with the thing, and if you are closely watching, you may have in your mind, I can go a little conservative here. But of course, a resection or end block with the lower border is a treatment, but we'll go for a peripheral ostectomy. Thinking that it is an anatomical safe area, the patient is well aware of it. He will regularly come for your follow-up. He's educated, he knows the things, he is available on communication, and he is ready to come. Then you can think of it. Otherwise, some patient in our setup, we operate, tell them to come after 6 months, they come after 16 years with a huge tumor. This is what usually happens in our setup. In Indian setup, in Western countries, less population, well-to-do people may regularly have email and all those things, and they will come on the day of appointment. But here you will not get it. So that's a problem. So this is not a real management thing for peripheral ostectomy, but we do this for a little lesser aggressive lesions, not for Amiloblastoma. But if at all we are doing this, is the reasons. Okay, in safe areas only. Don't in the ramus area and all. Go for this, because if the patient goes 3 years later, the lesion will be the infratemporal fossa. And how much you are going to resect in the infratemporal fossa. And cranial base, you will not be able to operate. Okay, and you may lose the patient not suddenly in a 10 year, 15 year. That is why the survival rate is 17 years. They're given like that. So we are not seeing the patient. They may see the patient after 25 years in some other center. You might have been the first surgeon who operated with a peripheral ostectomy or a curettage. So Carnoy solution, which is being applied for, which is for the margins to destroy the normal tissue there around. In all those kind of lesions, Odontogenic keratosis or tumor, we do that. In Amiloblastoma, we do that. The contents of that, you should do glacial acetic acid, and nowadays that ferric chloride is added. Chloroform is not taken away from that now, because that seems to be carcinogenic. So the preparations don't add chloroform nowadays. In US, it is banned by the FDI there. So I think better to have a carcinogenic property of this thing and all has to be studied. We are applying it with so far evidence, but this can be a cryosurgery is another one. You freeze off the normal tissue around the margin, do a peripheral ostectomy, freeze off the margins, okay, not allowing any of the seeded tumor there to recur. You're destroying the thing, any seeding there, that seeding has to be destroyed. That's why you're doing this. All around the cavity, with a carnoise you can do that, or you can use a cryosurgery, or you can cauterize, okay. But definitely it's never a foolproof method of completely destroying the tumor cells. You may still microscopically leave it behind. You know that the lesion is still there, okay. Sometimes psychologically also you feel that I've done something great and you may not come back again. Now, nerve involvement in Amiloblastoma, I was mentioning about to you. Some people, Nakamura says that there is no nerve invasion seen. Okay, squamous cell carcinoma usually affect the nerve. That is why you get a paresthesia of the lips for squamous cell carcinoma. You will not get that for an Amiloblastoma. An Amiloblastoma man will not tell you I got paresthesia of the lip, but a squamous cell carcinoma or a metastatic tumor fellow will get it. Now, recurrence in Amiloblastoma is a headache. Recurrence, one main thing is curettage and enucleation invariably will produce recurrence. Okay, that is why it is 55 to 100% in solid, because you have done a conservative approach. You are left behind the tumor. That is the reason. Yeah, if you did it well, this rate will come down. Intraosseous 80 to 35, because the other side, it may invading the soft tissue also. Okay, here you will be able to contain within the bone and you may be excising out. You can prevent it. So intraosseous it is lesser. In resection, it is only 15%. See, in resection, it is 15%, and in curettage, it is 100%, 55 to 100. Peripheral ostectomy, all this 100%. 55 to 100, very huge presentation. You will get it. Resection 50%. Curettage 55 to 99%. And you can sometimes produce a lung lesion also. Posterior maxilla 100%. Okay. Whatever you do, the posterior, that is why we have completely removed the maxillectomy and whatever with the frozen section. And you have limitations in operating in that area. Now, frozen section, I was mentioning to you, typically practiced in many centers, colleges, government colleges, we still find the difficulty, but most of the cancer center definitely got frozen section. Every case they do that. The surgeon will go and discuss with the pathologist, watch the slide himself, get convinced the tumor is removed in everywhere, you're clear with the tumor, then only you close it. Okay, from the theater you make a decision, yeah, tumor is completely removed, then only you close the thing, or you go back, resect again, give it back to the pathologist, look again, confirm that it is clear, and then close. That is oncosurgery is all about. You cannot leave behind. The eye is involved. The eye may have to be exonerated. You can't think of losing one eye. Patient will look miserable, but you can't leave the eye behind. Then you're killing the patient. So again, total eradication of tumor, keeping an anatomic border. I was mentioning about, see how we have cleaned. You can see the normal bone added here, 1 centimeter, and here also. That is why it is disarticulated. It is extending till here. You cannot retain the mandible condyle or the ramus here. You have to do the hemimandibulectomy. It's taken out, sent for frozen section, sent for calcified studies, make sure that it is clear the margins. And all the soft tissue covering also removed. See, that is almost out. You can see slight perforations here, and overlying soft tissue has also to be included. The complete thing is taken out, and a reconstruction plate is kept, or primary everything is closed, nice, you are confident, you can give a bone graft or your primary reconstruction. Now, approaches, the typical approaches for a maxillectomy and wide area maxilla access, a Weber-Ferguson approach is very good. You can extend it on the with a canderal incision here. You can add an orbital extension with this. You can, with this, you can go see the infratemporal fossa, nasal area, all can be approached. It's a very versatile approach by Weber-Ferguson. And the lip split will give you a nice access to the mandible, entire mandible, the nodes here. If you find some nodes involved, you will give the node also for the biopsy. Sometimes we, in the node also, ameloblastomas, people call it metastasis. It could be a local spread only most of the time. Okay, so a lip is split and a very anesthetic scar will be there. But the lip is split here. If you don't do a lip split, you can tunnel and do it. But what happens is your access will be compromised. Your access to the mandible will be compromised, and you may compromise in leaving behind some tumor cells. That's a problem. You go for aesthetic incision. I don't want to give a lip split. I will tunnel and do it. The problem is you cannot nicely do a medial side dissection. You will leave behind some tumor. You think it's a beautiful surgery and plate it and put a graft and all, and put 2 implants on that and all. He comes back with an ameloblastoma. And see the hemicoronal approach. Now here the tumor has gone into the zygomatic arch and the zygomatic bone area. Then you need extension here. As per the tumor going, we have different accesses to remove it. And sometimes we need access osteotomies to remove tumors from inaccessible areas. In the infratemporal area, the tumor is in the infratemporal area. You can go by a mandibular swing osteotomy. Very easily, you can swing it and the tumor will be removed and you can put back the mandible. Here, this is one case operated by me. The patient had a swelling in the somewhere in that base of the skull area. Okay, so we did an access osteotomy with a Lefort 1 down fracturing. Just like our orthognathic surgery of Lefort 1. Same thing. He's an old man. There's no teeth for him. He's an edentulous guy. We did a Lefort 1 cut like that. You're down fractured. And when you down fracture, you can access to the posterior aspect of the maxilla. Near the base of the skull, the foramen magnum area itself is possible. You can nicely bring down the maxilla and go and remove the tumor there and put the maxilla back. So this is a wonderful option. Access osteotomies. Most of the cancer hospital people call us to do this access osteotomy as and when needed. In our center also. In RCC, when I was in Trivandrum, regularly they call, we go and give an access, they may remove inaccessible one, squamous cell carcinomas from all of those inoperable areas and put it back. It's such a very novel idea, which is very commonly practiced. I'm sure Dr. Joyce, all will be undertaking this in their center. And access osteotomy, I was mentioning the mandible, there is a lesion here. Can you see a lesion here? It was a neurofibroma just outside the ramus of the mandible. Okay, if you are doing it without approaching this way, you have to do a wider dissection and you may not be able to operate well. Here, mandible is cut like this, an L-shaped one, taken, opened up on both sides, lifted up, and directly you have the access. It is removed, it's an encapsulated one, and put back plated like that. Okay, neurofibroma, it is not that dangerous one. The entire thing is removed, you can close it. So I just put an access osteotomy 2 pictures to show the way the surgeons are nowadays evolved and these things can be done. Now radiation in Amiloblastoma, I just put a slide. There are a lot of articles on that. They don't mention it for all cases. It is done only when in a very cases which cannot be operated, inoperable ones. Okay, it is not the common treatment for Amiloblastoma. If there is nothing can be done. It's a more of a palliative thing. Many of the lesions of our jaw region, many goes to neurosurgeon very late, and when I ask them, they said they regularly get it. Maybe all not detected lesions and all. And such cases, they give radiation is what they give, or chemo is what they give. Neurosurgeon, they cannot operate. It is in the whole brain. It is there. Now, the patient may suppress and he may survive for many more years. That's the only thing. Now again, chemo, same thing. Again, it is not used in metastatic lesions. There are real chemo failed. In Lanham, he say the chemo failed in Amiloblastoma. In inoperable cases, not our common lesions. Dufay says no response to chemo. Okay. And Gremwald says it responded to paclitaxel and carboplatin. So, many information are coming. We don't know. In future, we have some drugs which may be of help. Now, solid multicystic, I was typically telling this a boy, which we have operated long back. There's multi-locular here. The treatment plan was straight away. Look at the lesion here. We can't retain the lower border of the mandible. Okay, we have to remove the tumor with a normal margin on all sides. And if at all any soft tissue covering that also has to be removed. This is the one resected out. Okay, resected out, and just a reconstruction plate is given. A plan for a reconstruction later. It's a young boy. And this is the post-op. Doesn't look much of a cosmetic problem. If you look back the resections in 60s and 70s and 80s, we see many cases, the collapsed mandible on one side. You see many patients walking. And the surgeons used to do this hemimandibulectomy in all those days. And for every lesion coming on the mandible, they used to do hemimandibulectomy. That was the sad state on those days. We can't blame the surgeons. They also have very little information on jaw tumors. So a periapical cyst also treated by a hemimandibulectomy. A dentigerous cyst is treated by maxillectomy and mandibulectomy. Remember the patients in 60s and 70s, no reconstruction. The mandible collapsed to one side and they walk like that. They cannot talk or eat or anything. When I was doing my internship and post-graduation here, one of the engineer working in my medical college from the PWD side used to come with a mandible collapsed to one side. He had an Amiloblastoma, which was operated in the 70s. The mandible is taken out for a small lesion, which should have been done today by a small peripheral segmental resection and a reconstruction. So it has improved a lot. See, the patient's cosmetic can be retained and very beautifully treated, absolutely reconstructed very well with implants and tooth and all. Okay, most of the centers in the high-tech centers nowadays, corporate hospital, everybody do primary reconstruction on the same sitting. 2 teams, the reconstruction team on one side, and in our centers, Manipal and here Calicut, Mangalore, everywhere, Yenepoya, I think everybody will have microvascular. We team up with a microvascular surgeon. Max Fac people itself are trained in microvascular surgery, and beautiful job is done. Meticulous work, of course. So very good results are provided. Again, so look at this case. It is inverted out. It's heated up the bone. It has definitely crossed into the soft tissue. Look at this. Okay, you have taken this out. That doesn't mean the tumor is not out. You have removed the bone out, but the tumor is gone in definitely into the mucosa and the buccinator and everywhere it will be there. This is the buccal side, lingual side also. Examine every side. Wherever it has infiltrated, if possible, has to be removed. Frozen section has to be done. Confirm on the table and then only close it. Now again, anatomical location, I was telling the maxillary ones are ominous. Okay, here, don't play around with this lesion with the conservative approaches. Okay, it is definitely going to give a huge impact. The maxilla will be involved and the patient will have a cranial involvement very soon. So better to go for a wide resection right in the beginning itself when you get a maxillary lesion. Look at this guy whom we operated. Both the maxilla and the mandible is involved here. Okay, what we have done is we have published, this is our study where we studied the margin around 0.5 to 0.8 mm we have seen to be clearing the tumor. But many studies say 1 has to be required, 1.5 centimeters. This is published in the International Journal of Maxillofacial also. I have presented this in the international conference in Bangalore of our association. And this is the continue, I told you, retaining the lower border and how do you remove the tumor. Just a demonstration of that. Here the tumor is safe here, it is not entered here. That's why we have retained the lower border. Otherwise, you have to go for a wider resection. Now again, same patient, one more picture, we have resected out and the reconstruction plate kept. Another guy with a resection. See, the disarticulated, the tumor is still here. Till here it is there. Okay, so, and the lingual side, both sides you see. Definitely you need soft tissue also. It's an Amiloblastoma again of a young boy. See that, okay? So that is how destructive these are. So there is just, the kind of things we do. Just a resection I was just showing. I'm going a little more time I'm taking, but I think I'll proceed for a few more slides. As Vinay said, the time is 45 minutes, but maybe 1 hour or a little more than that. If everything fine, I can continue. This is struggling with a giggly saw, and nowadays you have oscillating saw, so you can very well manage with that. So this kind of giggly gives a clean cut, but an oscillating saw is very good. But better than the micromotor, which may certain kind of body powder will be left behind. Oscillating saw will cut like through the butter with a knife. Now look at this pre-op, post-op, that guy where the maxillary mandibular case was done. We could not really remove the entire maxilla was powdered like this. We squeezed out more of an ability thing we did. Okay, this is the mandible entirety we could get, but here we could not get any of the borders of the maxilla or anything. Okay, definitely this guy need a very close watching, and already the lesion may be in the cranial cavity. We could not really rule out. He still followed up. He was 47 that time. Now you can see I told you temporal region, temporal flap is raised, zygomatic arch also removed. You can see the arch over here. You have to go wider. These all can be removed compared to, not like your eye and all you can reconstruct. But when it comes to eye and other inoperable areas, it is really a decision making is very difficult. Again, angle to angle is resected out, okay, for this particular patient. You cannot no way do any conservative approach at all. You cannot eat or talk or anything. Patient was sitting in a house, not going to show anybody for long, long years. Otherwise, you never get such huge lesions. Another girl, in the initial time, we used to do a lot of autologous grafting. So we only did this rib grafting here. We took the 6th rib here. We cannot put implant on this. But that time we did a lot of autologous. The rib was adapted like that on the bone plate and put there. And some consolation for us also, done something with the bone. Okay, and we are put here with the rib graft there. Definitely some case that rib will have given narrow mandible there. You may not be able to implant, but some bone sometimes we get. And this rib grafting, I thank Dr. Varghese Mani for giving me training in all these things, and I very confidently can take it now, thanks to sir. And I have seen some of his cases where he took the deep graft, just put 2 introischius wire in the end of the bone, and nicely taken up after many years. So just with the rib tied to both the end of the margins with the introischius wire, I have seen a few of his X-ray, whether it has evolved into a nice mandible. Sometimes you get that result. He doesn't have a full series of that. He was telling I will collect that previous one also. Otherwise, I should have presented that. Anyway, microvascular has given a solution to all those things, and we get a better result. Now again, another one, intraoperative frozen section. Already I mentioned that. Again, disarticulation I mentioned. Why do you go for the entire mandible? These are the enormous ameloblastomas which sometimes we get. This was my own case. A patient reported like this. It never went anywhere. She was scared and sitting in her home from the border of Kerala and Tamil Nadu, from Kanyakumari. She has come in Trivandrum with this one. Okay, and this patient has severe hypoproteinemia. This ameloblastoma, the whole thing was fully covered with protein containing solution, just like your tender coconut. When we operated, the whole thing went out and we got a shrunken mass like this. Okay, and operating, you have to be very careful. You have to take care of hypoproteinemia and things like that. This was the picture. We resected out the whole thing and removed the whole thing. And she never knew that treatment was possible. You know, we almost in entirety we removed the tumor, excised a little bit of skin and soft tissue, or put a reconstruction plate. Okay, and very nicely, this was the post-operative view of the patient. This is a post-operative view. And she was very happy, you know, she didn't come for treatment for many years. She should have come right in the early time and never enlarged with this kind of thing. African series, you get many of these cases in Nigeria. This is a ameloblastoma. You can put it down like that. Look at the size, you know. Again, same like the other lady. Okay. And malignant ameloblastoma. Lesion, which continues to resemble the conventional ameloblastoma. You get a node nearby, you send it for biopsy, you get an ameloblastoma histopathological picture. But you find it at a closer distant areas, then it is resembling the same parent one. So it is not there is no malignant transformation, no carcinomatous changes. So because you found it somewhere away, you call it metastatic ameloblastoma. That's all. I mean, malignant ameloblastoma. So that terminology is that much only. But ameloblastoma carcinoma is a malignant transformation, which will clearly be a carcinomatous picture in the histopathology and treated like any other carcinomas. So that is a picture of ameloblastic carcinoma. We had a case, we have published that, and only one patient I have seen in many years of ameloblastic carcinoma. Maybe some patient might have went to other specialties, so we have no idea. Advantage of reconstruction is very important. It gives a lot of psychological feeling for the patient and all those things. And things like humoral, what are the causes for ameloblastoma, humoral aggression are studied. I'm just putting some slides to tell you. Many research have been done on this, and some evidences have been available. But follow-up of 15, 20 years mandatory for all these aggressive lesions. This is the longest follow-up I had for one patient. This patient is followed up for 23 years. She had a curettage in the beginning, a peripheral osteotomy then, a segmental resection then, one more segmental resection then. 2 surgeries in the end was done by me. 2 was done by my one former surgeon. Still, she is fine, perfect, coming up for follow-up every 3 months with CT scan, and that way we are managing. But many we are not getting for that kind of a follow-up. Now, management outcome, I already mentioned, 80 to 100% recurrence in conservative approaches. Better not go with those kind of things. Calcifying epithelial odontogenic tumor, now I'm not going into details of that. A pin box tumor, which is also aggressive, and this is one of our case we operated in Trivandrum. You got an aggressive lesion. Look at that clinical picture. A lot of amyloid will be seen in that thing, and least scan appearance of the cells by the oral pathologist. And we resected out, and it is aggressive. It is a recurrent one. It is going to recur with resect with a 1 centimeter margin. That is a choice that we publish also. Vinay is also involved in that, right? And Dr. Shobana. We are presented in the journal of in that LCVO one that is published in Oral Biology and Craniofacial Research paper. And there is a CEOT, another picture. I'm just going through that. It's again with the 1 centimeter resection, reconstruction plate, CEOT one more. A surgeon must be a pathologist who does operations. Adenomatoid, much less aggressive. Nicely, you can enucleate it out like this and apply a carboy solution. Most of the time, that is enough for adenomatoid. Another case of adenomatoid. Ameloblastic fibroma. Ajay was showing one case. Okay, very differentiated between odonto. Once it calcified, it may look like an odonto. But this also is a very innocent lesion. Rarely, malignancy reported in recurrent cases. Now, just to show you the Calicut city from where the paper is coming, many of my you have traveled to Calicut and Chhatra and all, maybe knowing all these things. I may bring some halwa to hostel and you might have also tried that. I don't think so. We were staying in the same hostel. Okay, the Calicut halwa, the chicken biryani, all of you will be very hungry, I know. Even I cannot resist this picture. And see the beach of Calicut, beautiful. And this is Assam Street. Okay, anytime you come, you don't miss to visit these places. And odontomes, I'm not going. It's a treatment part is removal of the entire odontome, identifying it. But as Ajay was mentioning, make sure that but the best choice is fibula, which can be done with a what you call double barrel technique. So this is chondroma. Again, excision is enough here. Osteomas can be excised out, torice, mix of fibromas. These are all you get after the biopsy. You get the mix of fibroma. All are benign and not that really dangerous. Benign osteoblastoma, but you send for biopsy, you get a sarcomatous lesion. Is it over the time? Or I just finished with the 5 minutes. Is it audible?
Yes, sir. Yes, sir. Fine.
Yeah. I'm just finishing. Yeah.
All right.
So that's ossifying fibromas. Ossifying fibroma. Again, remove the tumor out, and you don't need a normal margin and all. Okay. Fibrous dysplasia, very self-limiting lesion. You can do a shaving of the bone for aesthetic purpose alone, but usually in the third decade it subsides itself. One picture of fibrous dysplasia. Osteochondrome of condyle is a common lesion. You have to take it out and see the biopsy and see. It could be a chondrosarcoma. It could be a a condylar hyperplasia. The X-ray you can't make out anything. That is published again. Osteochondroma, CG. I had done a lot of paper on that, and I have published in the international journal. This was one of our first early cases. You do a central giant cell granuloma, can be managed by non-surgical method. Now many centers use that. Steroids will reduce the lesion, because the osteoclastic action can be reversed. Calcitonin is used, interferon is used. I cannot go now because it is lengthy. This is the one before and after treatment of one of our case. And that is the, you don't have to resect in such cases. This is my professor. I would like to mention him here. And this was one of my first publication along with him way back in 96. Now this is another one. Here you drop your big knife in lesions of CG. You can manage with non-surgical, very good results. Calcitonin also provides excellent results. Non-surgical option is mentioned by Jacove. He is the first one who tried this steroid. Cherubism, very peculiar lesion. The cherub look of the patient, self-limiting most of the time. No answer surgically. Even now, people are treating with medical management, things like that. Again, luckily, sometimes it is self-limiting. Giant cell tumors you get, aggressive sometimes. Eosinophilic granuloma, plasmacytoma, hand-shoulder Christiansen disease you may get. This was the access osteotomy I was showing. This tumor was removed from the base of the skull area, and the biopsy report was plasmacytoma. Okay, it was removed from that base of the skull by the neurosurgeon. I provided the access osteotomy. Plurilemoma, benign fibrous histiocytoma, some of the things we have rare. We get 1 or 2 or 3 cases, so we have no evidence for these lesions. We want meta-analysis to comment on this. Pleomorphic you can get on the jaws, on the palate is very common. Sometimes the report will be adenoid cystic carcinoma, lymphangiomas, vascular lesion I have to mention here. Difficult to contain within this 45 minutes, that is why I'm exceeding. You really need a 15-minute discussion on hemangioma. I'm not doing that now, but you know that there is medical and non-surgical management. This is one of her case. Okay, that was manned by embolization of the lesion, which is feeding to the tumor. You see the external carotid, which branch is there. The interventional radiologist will nicely embolize it and control the bleeding, and you can excise it. Okay, so it has advanced so much to control these lesions. AV malformation, highly dangerous lesions. Okay, very rare, but very careful when you come to the oral cavity. Any of the cystic lesion you see, you have to be very cautious for a vascular lesion. I'll tell you why. Look at this patient. I just want to put the video here. You can see a fractured upper lobe right here. Yeah, and you can see a attempted extraction from a dental clinic. And luckily there was oozing there. He immediately sent to the medical college. He could not control bleeding. He came like this with an attempted 8 extraction, could not remove case to the casualty. One of my senior resident attended the case with an assistant professor. There was oozing all around. I'll show you the video. You look at the video, you know. Luckily, this patient survived. Look at that closely. See the pulsation there. Look at that. The entire 8 is getting lifted up in the socket. Have you seen anything like this? Your tooth getting lifted up from the socket like that. You know? Highly vascular lesion. You know, you may miss it in your clinical diagnosis. Then it is gone case. If the tooth has come out in this attempt, you know, the patient should have, you know, real bleeding and might have died there. So that is the danger of that lesion, you know, how dangerous these lesions are. And later on, it was identified and locally managed that time. Then later it was embolized. I think the patient that time went to Sri Chitra. That time the embolization facility was not there. He was referred there. They embolized and excised the tumor, and patient is fine. But any lesion, an odontogenic unilocular or anything coming in the oral cavity, look for bruit and vascular pulsations and thrill in their clinical examination. Always see that you aspirate the lesion and see that what is coming. In a high vascular lesion, you put the syringe inside, the blood will push back the syringe of the piston of your syringe, filling with blood. That will tell you is highly vascular lesion. And in hemangioma also, the blood will be filled. In CG, you can get blood. In aneurysmal cyst, you can get it. But high vascular one, you open up, you may have a lot of blood loss and hypovolemic shock, and patient may be lost in a peripheral center. There is no facilities, patient may not survive. A pseudo tumor of hemophilia, we had a very rare lesion we got there. Patient had a hemophilia, developed with a lesion here like that. And we excised out, we got a lesion like this. Again, now he has reported back again with the recurrence. Okay, he has recurred again, you know. So hemangioma, hemophilias can give these lesions like this. Very rare. We might have going to publish it very soon in one of the article or journal. Sometimes this kind of angiomatous hyperplasia, only once you send for biopsy report, you get a sarcomatous lesion will look like this. A leukemia patient will have a picture like this. When you send it for biopsy, you get it. Osteopetrosis, we get it. Rarely we get lesions like this. You can't touch the patient only. The bone will never heal. It is like this. Fracture coming again and again. Long bones will be affected. Patient will be looking very dwarf, multiple fracture on the lower jaw. Nothing can be done. Sinuses comes out. I remember one girl, still walking around. We give symptomatic management and go back. Now they are giving this for interferons and all. You don't know how good is that, and bisphosphonate, and many medical management is going on, and many specialists are involved in osteopetrosis. We get this vanishing bone disease. I got this case, you know, where the bone is just vanishing like that, highly destructive lesion. Okay, and again interferons are given here. This patient did not turn out. We followed up for 6 to 7 months, and we could not get him later. What happened to him? No idea. So before we condemn or upload an operator, we adopt him as an example. We should carefully examine his reasons for any given mode of operation. There is very specific reason when you operate, reconstruction option. And just putting a slide here, we have this autologous grafting, you have transport distractions, and you have the microvascular surgery, which is done nowadays. And many advancing things are happening, tissue engineering and developing your kind of bone outside with stem cells and all are coming up. Maybe in 10, 15 years, the whole scenario will change. You can see fibula with the immediate loaded implant here. Patient wear a denture after that and will be perfectly rehabilitated. There is increasing emphasis on preservation or restoration of form and function to improve the quality of life. Quoted by Jatin Shah in this oncology textbook. And we have all these high-tech things available, digital planning, stereolithography, 3D, and huge contribution from the radiographic side. They can nicely give you all the pictures and they can create your model. You can pre-plan the surgery, mock surgery. You can adapt your plate here. Everything can be explained to the patient. fantastic. Even centers like Chennai, Bangalore, we can send the thing. They're sending back the specimen. 5,000, 15,000 charges you're getting. Of course, the 4-in-1 will be 10 times expensive. This could be a synthesis or Y Lawrence 1. Not affordable for all the patients who are poor, total TMJ, reconstruction and all. Being done in centers with the limited access and things for all these things. The economical things comes as a big obstacle, and lot of research happening. Refine, research, and redefine. This should be the thing for all of us. And the budding surgeons and all the pathologists and oral medicine people and everyone, gene therapy, tissue engineering, nanotechnology, coming up in a big way, rapid pace. We could not catch up with what is happening in very few years. The whole scenario is changing. Tissue engineering, many mandible is made outside on animal models, and organs are developed. Molecular genetic aspect, giving a great thing about the lesions. Their clinical behavior, choosing medical management, everywhere you are now molecular investigation. Now just biopsy may not be enough in future to treat. You need a molecular knowledge and immunohistochemistry and things like that. Great pace and very difficult to catch up with all these things, and expenses and infrastructure and facilities. Research also being a little bit grunted in areas when we go advanced and all. Certain things we are not able to achieve or do. Some research you have to stop with the things like that. So we face this problem, and somehow we have to find answers for that. And the philosophical arguments about radical and conservative approaches are irrelevant considerations when weighed against the obligation to eradicate the lesion. The first operation should be planned definitely and offers the best opportunity for cure. The first operation is the best operation that the surgeon has to keep in mind. He has to use all the wisdom and the multidisciplinary approach to provide excellent result. These are the references. All of you have many other articles in our journals and all. Follow up all these things. Excellent textbooks you can follow on. And every day new publications are coming up. And that's a team of our Max Pack surgeons. That's postgraduates and my junior colleagues and our OT. This is our alumni meet of Calicut, where all our former PGs and staffs are there. You can see Thomas Joseph Sir, Lily Madam, who was a principal medical college, and the wife of our first professor, Dr. Rajivan. Ravindra Nair is there, George Karia, Nobison, Manoj Kumar, KMCT principal. All are there. Many are outside, and all budding fellows. So that's a happy team during one of our meeting. And with that, I thank the organizers so much for giving me the opportunity. Definitely, I have exceeded the limits and gone beyond the control. 45-15 minutes extra was given. I think I don't know how many minutes extra I have taken. So thank you, everybody. Welcome to Calicut, all of you. Our state AOMS is coming in Calicut. COVID has put a block to that. But once we recover, the next Kerala state is in Calicut. Beautiful place. All of you should visit. There's a Manajara Square, beautifully designed by one of our IS officers, Amitabh Khan, of Kapad Beach. It's a lovely beach and a lot of fantastic hotels. Great place to play football and to enjoy the place. Welcome all to Calicut. Thank you, everybody, for the patient listening. And thank you.
Thank you so much, sir, for very informative and interesting talk. I'm sure the postgraduate will come with many queries in the following panel discussion. Thank you once again, sir. Now we will move on to the panel discussion. I will invite our 4 panelists, Dr. Ajay Naik, Dr. Soumitran, Dr. Lakshmikant Chhatra, Vice Dean of the Yenepoya Dental College, and Dr. Joyce Queria. And this session will be moderated by Dr. Ashwin.
Thank you, Dr. Ashwin. So, without wasting much time, we will move on to the panel discussion. Thank you, Dr. Ajay and Dr. Soumitran sir, for a wonderful presentation. It was very mesmerizing, and I'm sure most of you would have benefited from your presentations. The time is a factor, of course. We know that it was very difficult to cover all the tumors in a very short time of around 45 to 1 hour time. But still, you managed to cover most of the things. I'm sure it was a wonderful presentation. So quickly, we will discuss just 4 cases, so that we will invite some of the inputs and some of the discussions will go on. We will take some questions also from the audience. So let me present one few cases, which is familiar already presented. Similar cases will just connect.
sit here.
I hope everyone can see the screen.
Yes, we can.
Yeah.
It's possible. Okay. So this first case is a 28-year-old male patient. Swelling noted in the jaw, lower jaw since 1 year. That is what his complaint is. It's very slow growing and absolutely no symptoms noted. And there was no trismus or dysphagia or any kind of problems as such, but the main problem was the swelling. Intraorally, briefly, he has hard bony expansion noted on buccally and lingually, and right from the right side of the molar to the left side of the premolar region. That is the information what we have clinically. And this is a picture. The patient intraorally, also there is a swelling you can note on the either side of the buccal as well as lingual side. And radiographically, the CBCT image shows some expansion, some radiolucencies, multiple radiolucencies, multilocular, and you can see the 3D images also. It's not so clear, but still, that is the information what we have. So, let me invite Dr. Chatra sir to put some inputs and how to go ahead with this kind of cases in the report initially, especially the postgraduate's point of view, how they are going to give such case when they report to the clinic or the hospital. Over to you, sir.
Can you please put it on slideshow?
Yes.
Yeah.
Yeah, good afternoon. Can you hear me?
Yes, sir, you're audible.
Yeah.
Yes, please.
No, the most important thing out here is I would advise all the postgraduates the one thing. Just looking at the radiograph, don't ever give a diagnosis. Please see the patient, or if the patient is not available, tell the patient to come out to your clinic, you to do the clinical examination, take a proper history, come to a provisional diagnosis, then you're looking at the radiograph. Please do not look at the radiograph directly. Is it my fault? My audio?
Yeah.
Yeah, I'll go back to the another. Now? Now it's okay?
Now it's little clear, sir. Yeah.
Yeah. This is the one thing I think I would advise. Just 1 minute. Please.
Somitran sir has to mute it.
I don't mute it. Okay.
Hello.
So Samit, yes, sir. Okay.
Yeah, I would advise all the postgraduate students, make sure that you see the patient clinically and radiograph, then you give a diagnosis. That's the first thing that you have to look at it. See, I have seen most of the time, even in most of the staff member as well, they're going to lift the radiograph first rather than looking at the cases. That's the one thing I think you should avoid using it. Even though the cases have been presented like this, you should be able to see the case clinically. This is what the advice I can able to give it. History and the clinical examination plays a very important role in diagnosing it, like the disease. Once you diagnose the disease, you can able to send it across and wait for the histopathological examination. That's true. I understand that. But you need to give a provisional diagnosis to go in for the correct investigations. So that's the most important part I would advise to all the postgraduates out here and the junior staff is that do not look at the radiograph directly first. Looking at the history and examination if possible, send the patient across to your clinic, do the examination properly, then you arriving at the provisional diagnosis and the investigation may be carried out based on that. Investigation always based upon the simplest procedure to the extremely available 3D investigations. This is what I would like to tell about this particular case. Thank you.
So when the clinical examination is done, what are the differential diagnoses you can think of such a case without any imaging things and all? If you go ahead with the clinical examination and chair side anything like aspiration or anything like that, would you suggest that?
You asking me?
Yes, sir.
Yeah, it's depending upon the case-to-case basis. It's not every case we're going to do a chairside examination as such. It's depending upon the case-to-case basis. Maybe it's required to go in for a chairside investigations, as simple as that of vitality testing to as high as you go in for an drainage of that particular area or an aspiration, fine needle aspiration, biopsy, or things like that. Depending upon the case-to-case basis, we need to look out for this. Not every case, and in the first order, you go in for the chairside investigation as such. This is what my advice to the people.
Thank you, sir. Ajay, sir, how about the imaging modalities? Have you directly going to for a CT images or CBCT images, or start with the OPG? Then we will move on to the higher images, or is it required to go ahead with the higher imaging modalities directly, or we can manage the OPG itself?
No, just like Chhatra sir mentioned, you cannot directly go to the higher imaging modality immediately. Once the clinical diagnosis is established and you have a list of differential diagnosis, you start with the easiest available imaging modality first. Because every dental clinic will at least have some form of intraoral imaging. So just get a few films. If it's not being covered with a single film, try getting a few films. And then maybe go on for an OPG, because the OPG would act as a screening radiograph. It may not give us all the pertinent details, but at least it will tell us where the location is, how much the extent of the lesion is. And then that imaging helps us determine if we are going to go forward for another imaging modality after that, or would that suffice? And of course, the 3D imaging modality will definitely help delineate, especially if you're going to go in for a surgical modality of treatment. Then all the details that I spoke in my talk, and Soumitran sir also mentioned, that the surgeon would need that information. So that is later for the treatment aspect. Just for the diagnosis, like Chhatra sir mentioned, the clinical examination would be very important, especially in this particular case that you're showing. The teeth are separated. So was there a tooth which was there in between, or has it been exfoliated? What is the clinical palpation? How are the teeth? Are they tender to percussion? How is the particular lesion which is coming out from the labial cortex? Is it tender on palpation? How is the consistency of the lesion? All these factors will go into thinking about the diagnostic pathway. Like I said, the diagnosis is not instant noodles. It will not just come immediately. All these, beginning from the history, like Soumitran sir also showed quite a few cases where they were there for either a short duration or long duration. So all those factors which the patient tells about their symptoms, the clinical examination finding, and then the imaging modality, it has to again go in a stepwise manner. And start with intraoral radiography, then you take the panoramic radiograph, and then determine what are the higher imaging modalities one would choose to. So in this case, primarily a panoramic radiograph can be taken, but the disadvantage of a primary panoramic radiograph would be being in the mandibular anterior region. There will be a lot of overlap with the cervical spine shadow. So once though the panoramic radiograph will have to be taken, we can see how big the lesion is. Once that is done, then you go in for a higher imaging modality, maybe CBCT or a CT, depending on the availability. And then you go about characterizing the lesion, what it might be. Under those 4 headings that I mentioned, the location, the periphery, the internal structure, and the effect on the surrounding structures. Once you have that, then you can choose your surgical path.
Yes, sir. Sir, Soumitran sir, would you like to share your knowledge regarding how to approach with the surgical intervention of these kind of Amiloblastoma?
Yeah. Okay. Yeah. So that's regarding the diagnosis, what Lakshmi and Jay has put as the way you go about, and planning again one depends on the diagnosis of the lesion. Because you, as I already said, once you get the diagnosis in your hand, the treatment is different for all the kind of lesions. If it is Amiloblastoma, you know how to go about. If it is something like an odontom, the treatment is entirely different. Or if it is something like what you call anomaloblastoma fibroma. So all the treatment which is required for that thing will be decided after the biopsy report comes, after the final diagnosis comes, consulting with the patient, their choice, his medical fitness for surgery. Would you go for a radical one? Would you do a palliative thing? If it is squamous cell, so the whole thing will be changed, and the whole these factors will come into play, and then definitely diagnosis is the one which will tell you immediately what is the treatment you're going to. Suppose you ask me straight away if it is Amiloblastoma or you're going to treat, I can tell you like that.
Thank you, sir. Thank you so much. We will take any queries from the audience. If at all anybody is having any queries or any clarification need to be done, they can unmute and ask their questions.
Are they typing anything in the box of questions? Then you can read out that.
So queries can be typed in the chat box also. Those who want to can type in the chat box so that we can ask those questions.
Ajay,
Yes, sir.
very nice presentation, Ajay. It was
Thank you,
wonderful
sir.
presentation. And my query is, when we have a lesion like this, which is crossing the midline or involving whole of the body of the mandible, how the 3D imaging will help us in reconstruction? Because when it is unilateral, we can mirror